Hello, do you hear me?
Okay, Peter?
Hello? Do you hear me?
Can you hear me?
Yeah, I can hear you
Peter?
clearly. Yeah, do you hear me?
So
Hello.
we should have live case number 1 from IKEM. Peter Peichl is in the lab.
Okay, I can hear you, but I don't know whether you can hear me.
Yes,
Yes,
we can hear you nicely. We can see you also, so you can introduce the case and you can start.
Yeah, hello for the second day of live cases. For today, we have one pre-recorded case of Affera and will be one live case showing multi-electrode mapping for atrial tachycardia. The patient we selected is a 64-year-old female with therapathy, and she's a congenital heart disease. She had, in the age of 10 years, surgical closure of atrial septal defect. It was the second type, and if we went to the surgery notes, there was a suture, only suture, there was no patch in the atrial septum, and there was a right atrial atriotomy as usual. Then the history is not that usual. At 2003, she underwent ablation of AV and RT in other centers, so not something you would really expect, typical for GUT patients. And then she had, for about 15 years or nearly 20 years, no recurrences until the beginning of this year, when she developed atrial flutter, typical atrial flutter, which is also common for these patients. And she underwent ablation of different atrial tachycardias in different centers. On echo, she has a normal ejection fraction. There is no residual defect on echo, on atrial septum. And the thing what was done about 1 month ago was ablation of the flutter, cavotricuspid line, and at that time they induced clockwise flutter and counterclockwise flutter. And there was also something which originated very low, close to the ablation line, and there was something done there. And they also one atrial tachycardia from the septum, something around the suture on the patch was induced. This was quite fast, 240 milliseconds, and this was ablated on the left side of the septum, so transeptal puncture to the left atrium, and the side there's the cardiomap is the red, so at the low septum on the left side, which terminated the tachycardia. And there was no inducibility at the end, which looked good. And the problem is that the patient's symptoms got much worse since this procedure. And this is the arrhythmia she is experiencing, according to her, nearly every day. And this is the ECG we have. And if you look at this as a narrow complex QRS thing, which at the end of the day can be anything. So it can be maybe not the typical flutter, but some slowing conduction, can be around atriotomy on the right atrial wall, and can be also even RT at the end of the day. So this is because of the morphology. It's not really helpful, and she's quite symptomatic. Somehow the procedure make it worse, which is interesting. But that's sometimes if you just slow down things, not to completely eliminate that may happen. So if you go for a next slide, it shows the sinus rhythm. Obviously, that's not that interesting. Left anterior hemiblock in a patient after surgery. So what we started to do, we used the multipolar electrode mapping HD grid because we believed it could be nice to show some scar and atriotomy scar in the right atrial wall. So we were beginning with when we started, we wanted to make sure that the cavotricuspid isthmus is blocked. And just to simplify things, if you go for something in the right atrium and you don't have the block in the isthmus, that's sometimes tricky. And we put the HD grid on the isthmus, and you can see there's wide separation of double potentials. So typical flutter isthmus is blocked, and the typical counterclock or clockwise flutter was not the issue. Obviously, you can verify that by pacing maneuvers, but I can assure you. During the waiting time, we did some maps. So first map, if we switch to NAVIC screen, is the pacing from the CS, just to show the propagation. And this is with the HD grid acquired quite rapidly and with multiple points. So this is the right atrium, and this is the from below. You can see the block on the covered tricuspid isthmus. Obviously, there's a one wavefront, and then is the other wavefront. And if you go to the right atrium, you see appendage, SVC. And if you watch for the lateral wall of the right atrium, what is interesting, and maybe not surprising if you do these procedures, but I would like to highlight this. It doesn't seem to be any scarring, any double potentials. It looks like a really kind of, there is no atriotomy scar. And if we would switch to the voltage map on the lateral wall, we would see the same. There is no real low voltage on the lateral wall. So we can try to do that for the voltage and change the more setting for the scar. And then we see that there would not be really low voltage when you would expect the atriotomy scar. Then we did another remap during pacing from low right atrium. And generally this will be the propagation map again. And again, you see not that much of the kind of atriotomy scar, which is a bit surprising now, because usually when you pace in the low right atrium, you can visualize the scar. So the question is, where is the scar? And what's the arrhythmia? And so, I don't know, you can bet now whether it's we know it's not a flutter. It's maybe something on the lateral wall, but we really don't see the atriotomy scar. It can be from the septum, and the thing you have to do is to induce. So when we mapped the lateral wall of the right atrium, we were sure that there is atriotomy scar. And if we switch to the map to the sinus rhythm, it generally is very nicely visible. And the point here is that if you play propagation map now, you have to have a somehow early activation point close to the scar or close to the line of block. And now if you this is sinus, which originates close to the line that surgeon did, you can now see that there is definitely double potentials. And just to illustrate that in a tracings, because the one thing is to look at the maps, but I still like to look at the raw potentials. So if we go for a real-time image for Pruka, can we go Pruka live? So this is the HD grid, the multipolar electrode, positioned somewhere across this atriotomy scar, and now you definitely see that there are a line of double potentials. They are not visible in voltage because they are not really low voltage, but there is a clear-cut suture from the surgeon, and there's this atriotomy scar. And if he pays now from the CS, so you will see suddenly that the atriotomy scar will disappear. Suddenly you have just one single activation, and that's the reason, because the activation travels parallel to the line. So there is no real clear separation. And this is the same if you pace in the low right atrium. So the ablation catheter now is positioned in the low right atrium, and if you pace from ablation, you see again there is no real double potentials in it, because you activate from the other side again parallel to the line of the atriotomy. So this is just to highlight that you have to do something to really know that you look for, and you have to pace in a proper way, or maybe in this time sinuses, we take advantage of sinus rhythm to really visualize the scar.
Can I have comment?
So the question is,
Petr,
was the tachycardia that originated from the lateral wall,
Petr,
or is
can
something
I have
else?
comment?
Okay. Yes.
We used to do for these cases screwing of the electrode, like temporary lead screwed just close to the presumed line, and then the closer to the line you are,
yeah.
then you can see nicely
screen or inside
double
screen.
potentials.
Generally, you're left with what the surgeon did. Some surgeons do it very close to or in the middle of the lateral wall of the right free wall. Somewhere it's close to the, I don't know, phrenic nerve, more posteriorly. On a NAVIC screen, you can see along the SVC, IVC line, there is a phrenic nerve, which you always look for if you want to do something in the lateral free wall of the right atrium. This is very posterior, so we are not limited by phrenic. this double line on the left, so we don't care about that much. And in this particular case, you see the appendage, and somehow the atriotomy line was done much higher than usual here. At least what the surgeon usually do here is the much lower line, and it's easier to connect. So this is what we have, and obviously then you have to induce to see what's the tachycardia. So any guess what this is?
Could be
you
whatever.
saw the ECG.
Could be whatever.
It can be anything.
You mentioned
it's not
it
the
could be
typical
even
flutter.
AVNRT. We
Exactly.
could do
So
adenosine.
if we go for the number 3.
We could do adenosine injection during tachycardia just to exclude AVNRT from any form of flutter or atrial tachycardia.
Can we switch to the review screen? And to be honest, to my great surprise, this is the 3rd procedure, and we could induce with ISO this thing, which most of you well know. It is AVNRT. The initiation is not typical. The initiation is more like a double his response, because we have one extra atrial premature beat, and you have 2 V's for this. Usually you have the jump and initiation of the AVNRT, but this one is, you have one conducted beat, and then is the initiation of the, so there's 1 atrium and two ventricles. Nevertheless, it is AVNRT that is inducible, and that was causing her problems. So the plan now is, we didn't do anything yet, and obviously I believe that this AVNRT is the clinical tachycardia. We could reproducibly induce it. When we pace really aggressively, we could induce AFib, which spontaneously terminated. So it seems that the other arrhythmias, like this atrial septal thing, which was fast, is not inducible anymore. And we are left with AVNRT. It's surprising that the AVNRT got worse. It recurred after, I don't know, 17 years after previous ablation. And it's now very frequent. Probably the flutter line did it, and some ablations there slowed the conduction there. I have no clear explanation for this. We don't usually see it, like this late recurrence, and AVNRT was not probably induced in the 2nd procedure. So this is what we have. So my plan, I didn't do anything yet, just to demonstrate the capacity, and these maps with the HD grid are really beautiful, because you can really play rapidly to see which is the best mode, with the pacing in the low right atrium, screw-in lead, or taking advantage of sinus rhythm to see the atriotomy scar. And the multi-electrode definitely shows double potential, so you really know where is it, and it can be used very nicely. And my plan, obviously, would be to start with the clinical tachycardia, which I believe is the AVNRT, and I will be sure to get rid of this one. And then we proceed, because it's a 3rd procedure. The flutter is not inducible, but we should still connect the atriotomy scar with some other barrier. So if we rotate to the lateral free wall, the white line somehow represents where the atriotomy is. So in theory, you have 2 options. You can go to the tricuspid annulus, and you can go down. This line seems to be more favorable because it's shorter, but in fact, it's the worst thing you can do, because usually that line towards the tricuspid annulus is difficult to block, because there's a lot of trabeculation, and the tricuspid annulus moves, there's a low stability there, and it's like dealing with the right-sided accessory pathway there, and doing a really large lesions there. So I believe, personally, even if the posterior line is longer, I would go for that line and try to block, and then show the conduction block there. And this would be the plan for this today, even if it cannot induce anything else than the AVNRT. Any comments to this?
I think if I can comment, there is high probability that ablation of the left side of the lower septum or this cavo-tricuspid line did some modification of the circuit and slow down the conduction, so that making the arrhythmia more incessant. So I think that was clearly...
It's true. It could be the ablation on the left side of the septum, because we know that some of the AVNRTs are ablated from the left side, and ablation there might did some. Now I would like to proceed with the conventional right-sided ablation of AV and RT, do some lesions there, linear lesion, then try to reinduce, go for maybe the left side, might be necessary, I don't know, it usually is not. And then we proceed with this line. But obviously it makes, to me, much more sense that the left atrial septal ablation might have done it.
Yeah, I think so. There is one question which I not fully understand. The ECG of the tachycardia has an A between the QRS complexes. I think that's a hiss, if I could see it, but if you can comment on that.
You mean the review screen? You mean the...
I did not see any A in between QRS complexes. It's a his bundle recording, if I can see it.
This is his bundle, and that is the lowest, the CS, so it's AV and RT activation, synchronous activation during, you have prolongation and this. And the initiation is not typical because you have like this 1A, the premature atrial beat, then you have a conduction towards over the fast pathway, and then you have a very long double response conduction over the slow pathway, and immediately back with fast pathway having the echo beat and AV and RT. So this is also for me a proof that this is AV and RT.
I fully agree.
Although the initiation, usually you have a jump in initiation immediately, but this is like a double his response.
Obviously,
we also have
you can do some pacing maneuvers like his synchronous
if we go to review. But if you go to the review screen and můžeme, Honzo, prosím ukázat takový ten junctional extra beat. We saw this double his response. Maybe increase the gain, increase the speed to 100 maybe. And if you go a little bit left, just to show the pacing. So again, what you have is the train. This is the end of the train. Is one extra beat. There's this fast pathway conduction. And there's another V, which is without retrograde A, which I believe is this double his response to one atrium. You have two ventricles.
It's actually a nice
so
example.
It literally looks like there is two pathways.
Yes, I fully agree with you.
And going back to worsening of AV and RT after previous ablation, sometimes you go for ablation in slow pathway, and at the beginning the arrhythmia is not invisible, and it can become incessant after through ablation in slow pathway region. So maybe it's a similar explanation with ablation on the left side, close to this region.
We can discuss whether
we didn't expect it, but it's the life, real life. This is what you get when you have these patients.
There is an issue whether to ablate also this right free wall of the atrium, but I would say yes, because the patient had already several procedures, and this is, although the isthmus is relatively long, as you show nicely, there is some potential for scarring and for another arrhythmia. So if we can, as Hiroshi Nakagawa a long time ago coined this, that there is no gap, no re-entry, we can really close this gap if we are already there, and we have very nice electroanatomical map. So I think that's for the patient good to do this line, even though you cannot induce now any atrial tachycardia from the post-incisional, typical post-incisional atrial tachycardia. So I would do that if we have all this setting already in.
Because if you ablate this AV and RT in this few months, it can become atrial tachycardia from that side.
Okay, let's start with AV and RT. Then we can maybe start with our pre-recorded case of pulse field ablation with Affera technology.
1-2 burns with slow pathway area, and then we can have the pre-recorded case. And
then we come back to you after the case, okay? So
I'll check the his, whether this is the same location, because we're waiting for the map may be shifted a bit.
Maybe we can have now
the map
on the main screen.
Position of catheter, yes, where it is.
So it's typical area of the slow pathway.
So there's probably something was done already because it's a redo of redo. And I believe there is we already have here, I will just remap the his because I want to be sure that, because usually these procedures take long, so I mean the live transmissions, there's some preparation phase and sometimes there's a shift because of the length of this. So this is a his potential still here, so I would mark that into my map just to be sure. Můžeme tady vzít, can we take here acquire yellow point, which generally it's a his cloud, I would call. Now I will bend the catheter and we start to have some better signals and we proceed with the ablation. I believe it is a little bit shift of the map, but nevertheless we have to have a relative. So according to...
Can we see signals now, please? Running signals.
So, can we running signals? Can we slow down
or
here?
Can we have both? Can we have map and also running signals?
Maybe you can show us pacing from ablation catheter before going for ablation.
Yeah, I would proceed with the ablation.
Okay.
Can we start 25, 30 watts? I really like the provocation.
So far no junctional rhythm.
Co se stalo? Tak můžeme nastavit vyšší tu teplotu.
So there was a switch
No, zapnula se tady.
because of temperature, but there was no junctional rhythm. So I think you have to go.
No, there was one.
Maybe one, but you have to go more to atrium, I believe. There is almost no atrial signal.
Yeah, but there's a previous scar, so I start with the ventricle, and according to according to echo, I'm quite already high. According to fluoro also. So můžeme tady 25 W?
There is already some atrial signal, as I can see now.
So this is negativity P wave. So this is not junctional, but
from coronary sinus
P wave is
ostium.
negative.
Yeah, it's junctional from the coronary sinus ostium.
And sometimes you remember this is not a typical AV linearity. I will still keep burning. I know it's not the typical junctional, but můžeme dát 30 W.
You see negativity. You see negativity of P waves during the application.
This was not sinus beat. There was a atrial rhythm from the ostium of coronary sinus.
Yes.
Although you say there is no atrium, but there was a previous ablation. So I believe we have to follow more the anatomical things rather than the real signals, because the atrial activity might not be there.
So
really.
this
and
is
we had
sinus
some
rhythm
junctional
now.
beats at the
Yes.
end, and also we have a junctional beats with a long VA conduction. So can we test for the AV conduction now, just to show what's the
I would test inducibility.
AV conduction? Can you use inducibility?
You can slow down, please, the speed, so we can see more.
Můžeme zpomalit to. So what's the conduction rate? So you cannot really make it up from the. Can we do the one extra stimuli with 450?
So it was before reproducible inducible by stimulation.
Yes.
There is.
Yeah, I would keep adding some points here, but
I think we should test
go
it, and we should
400?
test on isoproterenal.
So I will keep another 2-3 burns like this, and then I will test with ISO. There's still some slow conduction there.
It
Not
is.
that happy with this.
So Marek, complex procedure with a chance to show how to ablate AVNRT.
This was not the plan, obviously, but I mean, if everybody does it. It's just difficult because everybody does its own recipe how to do it, and obviously if I don't do it immediately, everybody will tell me that I did it wrong because I didn't use their approach. So maybe we can add to
the most
this
important for AVNRT ablation is safety. I mean, this is not a life-threatening arrhythmia.
Můžeme zpomalit a já tady ještě bych přidal 25.
And whatever you do, it should be safe. It's again negative P wave in 2-3 AVF.
No, there was some junction.
Yes, there was some junction.
You see, there is interesting phenomenon. If you have this junction or rhythm from the ostium, you have no double potentials in HD grid. So it means that it's coming like during pacing from low right atrium, you see nothing. Only when sinus rhythm takes over, you see this double potential in this HD grid. So it is clear documentation that this was not sinus rhythm, obviously, and it's kind of a junctional rhythm from the ostium of coronary sinus.
So you will probably test it now, and we can show this Affera case.
We will do one more here. Můžeme zpomalit tady 25 W.
See again, disappearance of double potentials and negative P wave in 2-3 AVF.
There's one junction. Yeah. No, tak mi dej 30, já jsem trošku níž. Stop! Okay, so we have few junctionals, flow junctionals, and I just want to be sure. So let's try. We had some response and did kill some tissue. Can we start? One thing is can we start with this 400 something extra stimuli just to see the slow conduction there?
You can slow down the speed.
Můžeme zpomalit tu rychlost. No, tak dáme 300 něco, to je some increase of the conductivity of this. Tak, pojďme ještě níž, 350. Tak, 330. Tak, pojďme ještě níž, 310. So by these burnings, we probably enhance the conduction of the AV node because previously was not conducting. Pojďme ještě dolů, 290. This is like ISO. This was not captured in atrium. Can we go 300? Okay, this was captured or not? No. So can we increase the pacing? But I mean the energies to have a capture. So 300, but the higher energy, and we start to give iso. Můžeme teda začít dávat izoprenalín. Ještě pojďme 300. Já vím, can we pay CS 7, 8? Pojďme ještě níž, 280, no. Pomalinku ještě s tím izoprelem poprosím, teď už to vypadlo. Zkusme přetahovat. Can we just try to burst pacing?
Or incremental pacing.
Can we just increase try to go really fast, because I believe with these burns we enhance the conduction, somehow heating up the slow pathway or the pathway AV node, because now we have a still conduction. Okay. Okay, so let's try with ISO. Můžeme dávat izoprenalin. So obviously now we will try to continue on this right side. If we will induce, we'll continue more, and then we go for the lateral free wall.
Maybe you can wait 1 minute for ISO and for this test of incremental pacing, and then we move to our pre-recorded case. Yeah?
So we're waiting for the ISO. Yeah. We will do burst pacing once we have a high rate of 65, so let's go for something like a 75 or up to 80.
I have some questions here. Okay, in order to create posterior line in a right atrium.
So can we now?
Can
we
I
now induce?
Okay.
Go.
Wow.
No, stop. Okay, so let's try this several times. We have about 80 something, so we go with more and we try to induce. Yes, sorry, I didn't.
I have some question here. In order to create posterior line in the right atrium, how you will deal with prevention of phrenic nerve palsy and risk of ablation of sinus node?
So generally we have a map of sinus beats, so we saw that the sinus node is out of the way. It's much higher than we planned to do. You see the white point on the Navix screen, maybe, hopefully yes. And then the phrenic nerve also we marked, as you can see there, again marked with this, so it's much farther up, and we will try to obviously not go to the vicinity of the phrenic nerve. And that's, I believe, otherwise, the more than I would afraid of complications is the problem that the right atrium is literally trabeculated, usually, especially in congenital heart disease. And to create transmural lesions there is not that easy. It's not the cavotricuspid isthmus is smooth. There's a lot of excavations, trabeculae, and sometimes a really thick muscle. So that's something you have to deal with. And that's I would more be afraid that we will have a problem to achieve. And obviously we should, if we start to do the line, we should finish it, because otherwise we can make films against worse. So before that on ISO we could reproducibly induce it. I would maybe try to repeat the induction, and then I would proceed with the lateral wall.
Okay, we will proceed with
simulation?
Video, and we come back to you before going to Homolce, okay? In half an hour. Let's start with a pre-recorded case, which Petr did
Můžeme ještě vyvolávat.
With Affera technology. We discussed today about Affera technology, and Hiroshi Nakagawa introduced the system to you. So Petr did shooting of the procedure we did together, and he will show you now with a narration all the case we did with this technology.
Hello, my name is Petr Peichl from IKEM, Prague, Czech Republic. It's my pleasure to share with you a pre-recorded case of ablation of persistent atrial fibrillation using Affera system. First, let me introduce the system briefly. Affera is a novel electroanatomical mapping system with proprietary ablation generator and pump. The mapping is done by a key component, which is a Sphere 9 catheter. It is a 8 French steerable irrigated catheter with a lattice type tip of 8 millimeters and has a large footprint. On the tip there are 9 uniformly distributed temperature sensors and millielectrodes. The system is enabled to create lesions by both radiofrequency and pulse field energy. Those lesions are done in point-by-point fashion with short duration of 1 to 5 seconds. On the right hand you can see the Affera catheter, Sphere 9, and the size of the lesion compared to conventional catheter. Now I would like to introduce the patient. It is a 65-year-old male who has a history of arterial hypertension, diabetes, and obesity with body mass index of 32.5. He has a AF history for about 1 year. He had 2 electrical cardioversions despite treatment with amiodarone. On echo, he has a normal ejection fraction and dilatation of left atrium. There are no valvular disease. And we believe because of the history, we will need to do a complex procedure rather than a simple PVI. That's why we chose Affera. This is the beginning of the procedure. You see it's 8:15 and we're starting. We use for cannulation of femoral veins ultrasound. We believe that ultrasound is the direct visualization and it's the safest way how to do the cannulation. This is, you see the needle just entering the femoral vein. This will be the introduction of the guide wire. From the right groin, we insert Achilles sheet. From the left groin, we use 2 accesses. We use intracardiac echo, and we use CS catheter. So this is the insertion of the cannula, and intracardiac echo is our standard. We use it for all our AF cases, and the CS catheter is, you can see now, this is proprietary from Affera, but any decoupler catheter can be used. This is Achilles sheet. Transeptal puncture is performed by guidance of intracardiac echo. This patient had a floppy septum, but despite that, the puncture could be performed safely and quickly. Now we had access with the needle, and now we will insert the sheet inside the left atrium. This is the preparation of the Sphere 9 catheter. You can see this is connected to the irrigation, and we will flush the tip. And before the insertion, we require ACT of 300 seconds. This is insertion of the Sphere 9 into the Achilles sheet. This is how the Sphere 9 looks like with intracardiac echo. It's positioned in the left inferior pulmonary vein. We begin the mapping with the map of the left-sided veins. In this step, we carefully map the anterior portion of left-sided veins. This is done to properly visualize the ridge between left veins and left atrial appendage. This was left inferior pulmonary vein. Now we move to the left superior pulmonary vein, and we focus on the anterior part of it in order to tack it. Once the anterior ridge of both veins is mapped, the part of this map is fixed. This was done right now. And the rest of the left atrium can be mapped freely then, and the ridge will be kind of retained in the 3D map. So this is the continuation of the mapping. We will increase the video playback to save some time. And now you see the creation of a 3D geometry by the Affera system. Simultaneously, electrograms are acquired and automatically analyzed in form of either activation or, in this case, voltage map. Color coding is analogous to other electroanatomical mapping systems. Cutoff values for scar is 0.1 millivolt, while the normal tissue has a voltage more than 1 millivolt. The catheter itself is bidirectional, is quite flexible for manipulation. We see usually only minimal mechanical irritation during mapping. Tracking of sphere catheter is based on magnetic field, which enables precise localization. Additional magnetic sensor is embedded in the tip of the catheter, which enables determination of the catheter rotation. So it's visible in which direction the catheter will bend. Similarly, like in other magnetic sensor-enabled catheters from manufacturers like Cardo. This, in our experience, greatly facilitates mapping. Now we map the mitral isthmus, and we will map the rest of the anterior wall. In the middle of the screen, you can see the number of electrograms taken. So it's a high-density mapping system. We will have more than 3,000 electrograms gathered during this mapping, which is happening within few minutes. And you see also the volume. So the left atrium is dilated, and the color do indicate there is a pre-existing scar, mainly on anterior wall and also on the posterior wall. So this is the rotation of the map showing scar on the anterior wall and on the posterior wall. Now we proceed with the pulmonary vein isolation. For pulmonary vein isolation, we used pulse field applications, and these will be marked as a green dots. The applications are controlled by operated by a foot pedal. Before application, we check the position of the sphere within the antrum of the left superior pulmonary vein. Now you see the first application of a pulse field, of first electroporation, and this is 4 seconds application. And you will see the signals before this first application in Pruka. This is the application. You see the artifacts from the pulsing, and then you see the elimination of all electrograms within that site. So it's very powerful. Lesions are placed in point-by-point fashion, similarly as in other ablation systems. In generally, electroporation, compared to radiofrequency, has a larger zone of only reversible tissue damage, where you may maybe later get recovery. Thus, we currently aim for quite dense lesion with interlesion distance of 6 millimeters. It may be possible that we don't have to do such a dense lines, but this is our current practice. During applications, we watch for the temperature increase. This is readings from the thermistors, and it's displayed in the bull's eye, the blue circle in between the maps. Although electroporation is not causing temperature very high, there is still some heating during pulsing, which indicates the contact. Absence of temperature rise generally means poor contact and maybe inadequate lesion. Now we move from left superior anterior part to the left inferior pulmonary vein. So this is left superior. Now we go on the carina and go to the left inferior, and we continue with the application. Again, the video playback speed was increased in order to save the time. We will continue on the inferior portion of the left inferior pulmonary vein and proceed to the posterior part. Within the software, there is a part that tries to interpolate all these lesions and interconnect them with a line. And if the interdistance lesion is more than preset value, for example 6 millimeters, this will be indicated by a blue line. As we approach to the posterior wall, we will approach the initial part, and we will see that those parts will connect, and there will be gap, obviously. And this is indicated by the system. Now we see the gap on the posterior wall, and we will add additional lesions to close the circle. Now we isolate the left veins. The isolation of right vein starts at the anterior superior aspect. Importantly, using pulse field here is safe in respect to phrenic nerve palsy. Nerves in general are very resistant to damage from electroporation. During pulsing, you see sometimes contraction of diaphragm here. This can be suppressed by muscle relaxation. This is echo showing the sphere in the superior pulmonary vein. Now we increase the playback to save some time, and we will proceed on the anterior aspect of the right superior pulmonary vein, and we decided to isolate right vein separately, as it is our common practice. Right veins have a different axis and are separated, and we believe that by ablating carina in between decreases the risk of reconduction. In addition, so far no PV stenosis was described with PV performed by electroporation. So we finished with the right superior pulmonary vein. These are 4 second applications of pulsing, and we proceed to the right inferior. This is anterior part of right inferior pulmonary vein, and in similar fashion we go around right inferior pulmonary vein. So this is ICE image in the bottom of right inferior pulmonary vein, and this is the resulting image of the right veins and the carina in between ablated. Now we proceed to posterior box. We start with the line connecting left inferior pulmonary vein and right inferior pulmonary vein. The same 4-second pulse field applications are used. In terms of esophageal damage, up till now, all patients with pulse field had no relevant lesions noted on esophagoscopy following the procedure. So we believe it's very safe to use pulse field here. On ICE, you can see that we ablate directly on esophagus. Esophagus is the structure underneath the catheter, and there are no lesions. Then we proceed to the roof. On the roof, only few lesions are needed to connect both superior veins. Again, the gap in the line is indicated by a blue line, which will disappear after filling the whole line. And again, we're using 4 seconds pulse field lesions here, the same as we use for pulmonary vein isolation. Now we proceed with the mitral isthmus ablation. For lesions there, we use radiofrequency energy because mitral isthmus is generally fixed structure, and we know that the radiofrequency may have a deeper penetration than the pulse field. We again check the position of the sphere catheter on intracardiac echo. These radiofrequency applications are 5 seconds long, so they are quite fast, a little bit longer than pulse field, and they are marked with red dots on the map. You can see that during RF application, the temperature rise is much higher than was for the pulse field applications. The lesions are created sequentially from mitral valve to left inferior pulmonary vein. In order to achieve complete mitral isthmus block, ablation in coronary sinus is sometimes necessary. These applications within coronary sinus are done then by electroporation in order not to damage circumflex artery. Cannulation of coronary sinus by sphere catheter is usually easy. This is real time showing a block or line of block on a mitral isthmus, so several lesions are needed. And we are pacing from distal CS, which is positioned below the line. When we finish the line, we perform a short remap and try to see whether there is still resulting activation, and it was there. So we decided to apply additional lesion in the middle of the mitral isthmus, in this area where the ELAS activity could be detected from pacing below. And we did so right now. We then see that we did complete the mitral isthmus block. We moved above the line, and you see on the left hand that the distance from pacing to the local activation is much more increased, and this will be verified also on the Pruka screen. This is distal CS pacing, and you see the distance to the appendage. Then we check all the pulmonary veins for residual pulmonary vein potentials. Additionally, pacing is deployed in all pulmonary veins. These are signals or absence of signals in left inferior pulmonary vein. We move from left veins to the right veins, again to check the presence of signals, and then we pace to see whether there is an exit block. So now we move to the right inferior pulmonary vein. There were no signals, and then we move to the right superior pulmonary vein. Again, pacing to see whether there is conduction. Finally, mapping catheter is positioned in the middle of the posterior wall. You can see absence of atrial potentials in the Pruka EP system in a few seconds. So this is in the middle, and this is absence of any electrograms. And when we pace there, those pacing artifacts or pacing stimuli were not conducted to the atria. Now we proceed to the cavatricus isthmus ablation. Again, radiofrequency applications will be used. This will be 5 seconds application. The position of the sphere 9 is checked by intracardiac echo. Now we move from tricuspid valve into the middle portion of the cavatricus isthmus. You can see the catheter nicely fits there, and we apply additional lesions. It usually takes 3 to 5 radiofrequency deliveries to complete the block on the cavatricus isthmus. Each one of them is 5 seconds. So it's very fast. So this was the third application. This is real time. And we move towards the IVC. And there will be the fourth application. And the block is complete. So this is the fourth application. 5 seconds. We check again with the intracardiac echo that we are close to the IVC or maybe in the mid portion. And this is pacing from proximal CS, showing delay activation of the lateral right atrial wall in the sphere. After completing the planet lesion set in left and right atrium, rapid atrial pacing was delivered. So if you watch the screen underneath the maps, you see the induction, and we were able to induce residual atrial tachycardia, which was stable and had a cycle length of 460 milliseconds. And the remap of left atrium was started. Within few minutes, we achieved or acquired activation map with superimposed propagation map, which you'll see. The color is coded, the earliest is marked by red. This looks like the arrhythmia is confined to the left atrial anterior wall. However, ablation there could isolate left atrial appendage. In order to avoid isolation, a short application of pulse field right now was delivered close to the mitral valve. These short applications are only 1 second long, and they are called reversible pulses because they lead only to transient localized tissue stunning. This application at mitral valve didn't terminate the arrhythmia, indicated that site was not critical for arrhythmia maintenance. Then we move to the upper part of the left atrial appendage or maybe anterior wall, which will be done in now. And there, when we manipulated, there was a lot of fragmented activity. We mechanically terminated the arrhythmia. You will see the termination right away. Now tachycardia terminated mechanically. We reinduced the tachycardia, and we wanted to verify whether the short pulse will terminate the arrhythmia there, replicating the mechanical termination. So you will see the reinitiation of the arrhythmia. Now we pace to reinduce. And tachycardia is ongoing again. And then we renavigated the sphere 9 to the site of the earliest activation, marked by red color, and we apply short reversible pulse there. This, within few cycles, terminated the arrhythmia. So this, we go there to the site of the earliest activation, and we apply short 1 second reversible pulse. Now. And within few beats, the arrhythmia terminated now. Then we verified this part is probably crucial for maintenance of the arrhythmia. We remap the anterior wall during sinus rhythm just to know where is the conduction towards the appendage, not to interrupt it. We don't want to isolate the appendage because the mitral isthmus is blocked and it would be very easy with the system. And we found a corridor of conduction close to the mitral valve. So we felt it's safe to ablate in the upper part, in the basal part of the left atrial appendage. And we apply permanent lesion there by radiofrequency energy right now at the site which we verified. Then we try to reinduce the arrhythmia. You will see the pacing, rapid pacing in the atrium. You see right now. And you see no arrhythmia is inducible. So it's very easy to ablate. This is the end of the procedure. You see it's 2 hours. And let me summarize now what was done. So we performed pulmonary vein isolation with box lesion. We achieved blocks on the mitral and tricuspid isthmuses and ablated residual atrial tachycardia from anterior left atrial wall while preserving early activation of left atrial appendage. It would be very easy to isolate, we didn't want to. And now I would like to highlight some of the important parameters of the procedure. To isolate left veins, it took less than 2 minutes of total ablation time, so it's quite fast. It was a little bit more, it was less than 3 minutes of total ablation time for right veins. This was due to the ablation in between the right veins. We believe that we should do it, but maybe not. For posterior wall, we needed 2 minutes of pulse field ablation time. These all were done by pulse fields. For mitral isthmus, this was done by radiofrequency energy delivery, and this was done less than 1 minute of radiofrequency time, but it was the line when the first pass didn't achieve complete block, and we had to perform one single additional lesion. This is due to the thickness of the tissue in the mitral isthmus. And to be honest, sometimes we need to do additional electroporation pulses in the coronary sinus. It was not the case in this particular patient. For cavotricutis isthmus, this was very fast, only 4 lesions of radiofrequency, only 20 seconds of total RF time for cavotricutis isthmus. So within 1 minute, you finish with the line. And this is one of the best things you can, the fastest ablation I've seen for cavotricutis isthmus with the system. We performed also 2 reversible pulses to confirm which part of the anterior wall is critical for maintenance and, of the inducible atrial tachycardia. And atrial tachycardia was abolished by a single RF lesion in the base of the appendage while preserving the early activation of left atrial appendage. I must acknowledge and credit here Mount Sinai Group and Vivek Reddy for introduction of these reversible pulses, which are very nice. They add another dimension to the portfolio of different lesions that can be delivered. I hope you have enjoyed the case. We believe that the system is a true game changer for ablation of persistent AF. It enables us to create complex lesion sets quickly, effectively, and also safely. So far, no esophageal damage or phrenic nerve palsies were described using electroporation and pulse field energy. Lastly, besides being a powerful ablation platform, the Affera system has all the features of advanced electronautical mapping system and enables creation of high-density activation, propagation, and voltage maps. This makes it a very versatile platform. I thank you for your attention.
Okay, I hope that you enjoyed this presentation of the pre-recorded case. And we can come back now to Petr and to see the update before we move to another hospital, to Homolce hospital, and see.
Měli jsme to nahrát, tam ten double potential, tam, jak jsem říkal, že tam byl. Ne, teďka na konci.
Petře, slyšíš nás?
Jo.
You can update us.
Yes. What was done, obviously we induce again AVNRT as usual. The AVNRT sometimes is not an easy target, and so we kept ablating. Can we go for the line on the slow pathway, I would say? So generally we started at the valve, as you can see below the his, and at the end, in the more to the CS, this is we will mark it with the mouse. We had quite nice, reasonable response, although the main problem here was that if we start to have junctions, immediately they start to be blocked. So can we go for this one that we have, can we slow down to 50 on the review screen? Can we go for review screen? Okay, so you see the junctionals, and you see also some at the end, it's not blocked. So the last one is already not conducted, and there's some extra systole junctional. So this was, but at the end, I believe we did it. We tried with ISO. We couldn't really induce it. Although I would really spend some time for induction here because I want to be sure that this one is out. And then we moved for this line on the lateral wall, and we did some lesions. And when I put it across this and towards up, the aim here is to have to see whether this will be delayed, and it's still not. So we will keep ablating. There's still double potential. I'm across the line, and we see that the ileus is the blue one. So with the green one is a little bit later. The yellow one, it's really split. So maybe I will have to burn there more on the line. I saw some delayed activation, but maybe there was a reconduction. So obviously I will spend more. It might be that I will have to ablate more. That's it. But I believe we had temporary block there, but it's not now, obviously. So we have to go on the line and try to, and I will do it during the sinus. And this one is delayed already, the IVC part. Just that the map doesn't fit really, because honestly, if I look at the intracardiac echo, I'm very close to the IVC, and now there are no electrograms here already. So this one is already IVC. So this is the IVC, I would say, junction right atrium when the ablation is. So it's not that long line that I have to draw. Can we mark here as a on echo? It's obvious that this is the IVC.
Can you show us echo?
Junction. Can we make a point here just to know that we should search along this, and maybe we can put this HD grid lateral to the, or maybe septal, or maybe lateral on the posterior wall like this. We can pace from, I don't know, yellow something, and we can see what will be the signals in ablation.
You can see again this software I introduced yesterday, that you have beat-to-beat update of the activation sequence, and showing a white coming from the sinus node when it was in sinus rhythm. Now it will change, obviously, depending on pacing site. So this is a new development from Abbott, which allows you to map beat by beat from the HD grid.
So for example, now I pace from the yellow 2-3 or 1-2. And as you can see, there is in the ablation, there is a separation of both. There's double potential. So I go along the line that I created. So this one is, if you see the real-time image, real-time tracing. So this is double potentials, and it's quite late. So I will just go around this. This looks good. This is early. So let's go. Ablace tady jedem.
It looks like pivot point here, or some gap.
And it should do something, hopefully. Okay.
Yeah, there's block.
I'm happy. I'm not always happy, but now I'm happy.
Did you see the change in? There was a significant.
Can we just show for the audience the review screen? I obviously will keep burning. Can we go for this? I will finish the line, and I will show you hopefully that.
You can shift to the right.
The position that much.
To show it.
Yeah, can we see?
The review screen.
Can we see the change?
No, doprava, review screen. Can you go?
Still.
And then there is a sudden change.
Okay, now you see.
It's the same like block on any line. It's amazing. I have, Peter, before we leave you, I have a few questions.
Okay.
There was another question stating that there was a P wave on outpatient ECG in the middle of. I did not see any P wave there.
Can you go for this ECG from the outpatient clinic? Můžeme technici tam ukázat ještě to EKG, so I will just one more time show for the audience. So go one more back. Honestly, you cannot say anything.
Yes.
That's my interpretation. That can be really anything.
So if you want to be sure, you have to administer adenosine and then record ECG, and that would make clear if there is atrial tachycardia or AVNRT. This was not done. Okay, then there was another question. Was dual response before initiation reproducible with equal PR1 and PR2 intervals? And was the decrement in conduction more than ERP of AV conduction? You probably did not test reproducibility, but we saw it 2 times, this dual response. So I think...
No, there was a multiple times you could do it, but if without ISO, you can have this some funny shaped... I mean, the slow pathway is really damaged. It has one previous ablation, then I did something from left side, and then it's some strange behavior. So, I mean, this is not native situation. So generally we had this double his response is the name.
Okay.
Double his response we had, and then we give ISO and we have the AVNRT, which was very slow, sometimes faster depending on ISO. So I believe that was some kind of AVNRT. Maybe we need Dr. Jackman to explain, but in generally we still keep going for the slow pathway, which we did, and we will retest this at the end of the procedure. I would really want to be sure that this one is done properly, because it's the 3rd procedure, and she was really symptomatic. So the left-sided ablation probably did something. I mean, to be sure with ISO, we don't really induce it. It's rare to have double his response or double ventricle response for during these AVNRTs. In clinical practice, it usually looks like AFib. And I mean, general cardiologists refer them as AFib, and if you really don't look at the ECG correctly, because there are the P waves, there's 1 P wave and 2 QRS complexes if there's a native double his response, and that's sometimes tricky for people. Just say, okay, it's some not very regular thing because it's 2 to 1. Then they say that's an AFib, and there's one nice paper from Sanjay Dixit that's showing that about some very small percentage of people referred for AFib are actually having this phenomenon. And it's important to recognize, because on ECG it looks sometimes very chaotic, because you have a lot of P waves, a lot of QRSs, more QRSs than P waves. And you just do one single ablation and the slow pathway, and it's all clear, and suddenly the patient is cured. So it's important to recognize.
There is one more question related to your movie, and that's, is there any data on silent cerebral lesions with electroporation?
Obviously, all these data should come, and they will come eventually. I'm very optimistic about the outcome of electroporation. There's a lot of things you can tweak around with the pulse amplitude, the number of pulses. So there are some data. We're collecting the data. I don't want to just give away anything which is not which is preliminary yet, but I'm very optimistic about the technology, because all the patients that we did, and some of them had a MRI, and most there is nothing, and I don't have the percentage what's there, but they wake up the next morning, or and the next morning they feel good. There's no real problem with them, and actually they don't have pericarditis after the electroporation, because there's no thermal damage, so they don't have even a small effusion. They don't feel the pain during respiration. So for me, it's really like magic, this system. So I'm very happy with it, and obviously the data about silent cerebral embolism will come, and it has to come. But I believe it will be at the level of the normal ablation. And obviously, this is something that has to be proven for the technology. But even without this, I'm very happy about the esophageal absence of esophageal lesions, absence of phrenic nerve injury, and so on and so forth.
I have to repeat again what Vivek nicely said, that electroporation is not like one procedure. It depends very much what technology you use, what type of catheter design you use, and because there are so many parameters compared to RF that can be different in different companies and different operators. So we cannot say electroporation does this or does that. I mean, it's really different. So we have to speak about specific technology that is used in specific design of the catheter. So this has to be again.
And also within the same design of the catheter, you can have very different setting for the pulsing.
Yeah, exactly.
And we went over the last year that we're using the technology over different kind of presets of the pulses, and we try to get better, obviously. So, and we are getting better with the remaps. So that's and it's incredible, really, believe me.
Okay, I think we can close this part from IKEM and we can move to Homolce. And just a last comment from anonymous viewer is amazing. Congratulations for your performance, both with a live case and also a video which was nicely narrated by you and showed all these advantages of Affera mapping system and ablation system.
Okay.
Thank you very much.
Thank you, and congratulations also from us.
Okay, let's move to Homolce Hospital. We see now the
Entrance to the hospital.
entrance to the hospital. And we see Vivek.
Oh, there we are. Hi, Joseph, can you hear me
Hi.
okay?
Yes, perfect.
Okay.
Floor is
So
yours.
we have
Floor
a
is
couple of
yours.
interesting cases. Thank you. So we have a couple of interesting cases. Just to get started, let's just recap from yesterday's case.
Yes.
So obviously we did the patient with javelin, the carotid coil. That patient went home. The VT patient, if you recall, this is the bioventrix patient. So when we left, we were still working on that case. And again, if you recall, we had induced 2 tachycardias. And our hope was to put the Petr or any multipolar catheter, but in our case, the Petr at the region where the exit appeared to be, where the stitch was, and to see if we could induce a tachycardia with hemodynamic support and try to map this out carefully. Unfortunately, we were not able to keep inducing the tachycardia. I mean, we were getting different types of it, and we were getting fibrillation. So we ended up placing a number of lesions at the areas. I think you saw the late potentials, particularly in the fold of the bioventrix, the fold of the invaginated myocardium. Again, we didn't have a great endpoint. We did a bunch of lesions. I should note also that before we stopped, we did shoot the coronary, and there was a diminutive branch of the LAD that did go to this general region. So we decided that if this patient should have more tachycardia, then we'd consider injecting into that coronary. So that's, I wouldn't say it's the most satisfying case we've ever done. But anyway, the patient's doing well. Even later the same day, was sitting up and should be discharged in the next day or so. So that was the recap from yesterday. Now, why don't we go on to today? We have a couple of interesting cases. The first case is going to be with Petr Neužil and Petr, who are in the next lab, and they're going to show a visually guided laser balloon isolation case. So, Petr, do you want to take it away here?
Okay. Okay, Joseph, can you hear me?
Yes, perfect.
I can't hear you.
You can't hear me?
Oh, now. Yes, now. Perfect. Okay. So guys, we'll come in the smallest room in the world. And actually, we are ready for answer the question of Joseph. He put on just the panel. So we have right now the X3 laser. This is a technology we are since 2004, I believe. And since 2009, the company involved like a highly compliant balloon. And this catheter itself, X3, is available in Europe since 2018. So what is the catheter about? They serve much better flexibility in terms of manipulation. As a single operator, before then it was not so optimal to say the single operator, because you can touch these 2 buttons and inflate the balloon and deflate the balloon yourself. Then Petr will show you the other possibility, to manipulate with the laser beam, to adapt the laser beam on the area you are really in the contact. And rotation button, when you apply, there are two aspects of applications. There are manual application combined with so-called rapid mode or automated rotation. And actually the energy applied is adapted to all these modes. So we will show you, please can you give me the green light? And guys, can you get lights off a bit? Okay, this is visible, the balloon inflated. Actually the balloon size is up to 38 millimeters. I don't want to get the biggest size, but what I want to show you that you have nicely controlled the rotation of the laser beam, which is now green light and it's not danger, okay, so we can just visualize only. And Honza will rotate continuously to adapt, to show you, to mimic the automated rhythm of rotation. So the full circle is going around, and actually we have the case of, can you bring the lights on, please? Lights on and green light off, please. So we have a patient, a very young guy, 46 years old, with recent AFib in the history. So he matched the East AF criteria to treat his very recent paroxysmal atrial fibrillation, actually with Shadwask 0, but he is on apixaban since they described, since I guess the beginning of this year, the AFib. So what we did up to now. So actually we have, we can show you what we did in actually regular distribution, regular anatomy of this patient. So we have CT done, but actually I don't want to show you because I really want to be focused only on this visualization. So actually you might know that the catheter, the system is equipped and it's going with 2 French endoscope. So actually this is a high quality endoscope which allows you to adapt the positioning up to your contact. And actually you adapt the contact, the sizing of the balloon. And actually what is more important, you can adapt the laser beam orientation actually in concert with phrenic nerve and with esophagus. So for all patients, what we are using right now, we have all patients with esophageal probe, temperature probe on site. So what we did on this guy, so actually with regular distribution of 4 veins, we did 2 lefts and right inferior one. And we will show you from the playback, so please focus on the laser console screen. If you can show, Mathieu, the left superior vein. Actually, it will be a little bit shorter than usual, but this is continuous automated rapid mode rotation. We will rotate around. And actually, I will answer the Joseph question. Actually, this left superior vein was done in 190 seconds. And actually it's very, very interesting when you get very, very high amount of contact, so you don't need to rotate the balloon as we learned from the previous smaller classic, so-called like Heartlight classic balloons. Because this Excalibur balloon really serves you very, very high contact. Actually, in the left vein, you can see on the right side that you can see not only the ridge, and you can just sometimes, depends on the sizing of the heart, you can even visualize the appendage itself. So, well, what we are doing here in Homolce, actually it's not always the same technique, but actually we like to get all veins isolated, actually to get around. So somebody is going only for the left sets of veins together without or excluding carina in between the veins. So we can go to the left inferior. Actually, what I should be clear that actually we didn't check the isolation yet. So actually we don't know if the veins are isolated. So this is a very nice vision of the left inferior, and you can clearly see how big amount of contact you can get with that kind of balloon. And actually the laser beam is really placed specifically on the side of the really nice amount of tissue. So actually any charring, any other stuff, or floating blood could be excluded. What is the most dangerous part of the laser application is to heat inside the artery vein. So actually, if you lasing the stagnant blood inside the vein, so actually it's the most thrombogenic situation. So you need to avoid the laser beam should be really placed on the tissue contact. So the last vein we did is a right inferior one. Actually, you can clearly see the anatomy. So when the right inferior vein is branching early, so actually all the balloon clearly contain all this circumferential, even plus visualization, all these branches. So actually you can appreciate the visualization of the anatomy, which I like. And actually this vein was done in 110, 20, 30, 40, 50, 60, 177 seconds. And actually all three veins we did by single rotation without any manipulation of the catheter. So the only one vein we didn't treat is right superior one. So actually Honza already target right superior vein. So actually we can go less light, please. And we can proceed now what we are doing. So first of all, we need to inflate the balloon. So actually, as I explained, we
can we have the screen of X-ray?
Push the bottom of the fluoro, actually the bottom of the catheter, and please show on the fluoro. I will give fluoro live. Actually, we don't like too much fluoro, but actually just to show you how nicely we inflating the balloon. And actually there's a marker on the shaft indicate the orientation of the shaft itself. So now on the laser screen, you can see very nicely the contact creation. So actually we need to reach, to get ideal contact, we need to reach actually some kind of angulation, because angulation could help. Actually, the catheter itself is not deflectable, but actually we really play with the sheet, which is helping us to manipulate and nicely oriented the catheter itself. So right now, what I like to go, the sheet in the back of the laser balloon, and this kind of balloon is a little bit robust than classic Excalibur, which serves you more freedom to heat through the tissue. So I think, Honza, are you happy with this?
Yeah, almost, yeah.
So I'm not so, actually, can we increase? Okay, now it's going, sometimes it's better to just pull the balloon outside the vein, and now it's really nice positioning. So what I explained, so actually now we have shaft on the posterior wall, and all the facing left is anterior part, and superior inferior is down. So actually we are ready to apply the beam. So I will play with the beam. Actually, can I get this? Mm-hmm. Okay, perfect. So it's a pedal you can control, and we will start hopefully with. Can we go up? Mm-hmm. Okay, perfect. Nice. So can you go left slide, guys?
So we can go.
Okay, it's too much.
So we can go
Okay.
even behind the shaft.
Okay.
And let's start
And actually,
by counterclockwise.
we can adapt prior application. We can adapt the laser beam orientation if we can apply really under the shaft. So actually, I rotate manually with the bottom. So I did manual rotation, and I will show you. Actually, all the circumferential is easily to apply. So, what do you want to go? Counterclockwise or clockwise?
I will go counterclockwise.
Counterclockwise. Okay,
From
so
here?
we will start here. No, we will start here. No, we will start here and go counterclockwise. Actually, you have two options: clockwise, counterclockwise. And actually, in any single minute, you can stop and you can switch to the manual mode, which is sometimes better because you can apply less energy if you have poor contact of the tissue. So, guys, so I will start
You have to start
with
with phrenic nerve
13 watts. Actually, what is important, we are on right superior vein, so actually we need to get phrenic nerve pacing. So can we go for capture?
Pacing. Capture.
Okay, so it's capturing. Okay, so we'll go through all the vein, actually, phrenic nerve pacing. So I will start, guys. So you will see. Actually, before I start, I will explain. So we have for the rapid mode two options: 13 watts and 15 watts, which is so-called equivalent of the other manual dosing. So actually, what we know from our own experience and the study, actually we showed the X3 study that when we applied most of rapid mode for 13 watts, it's highly enough for all the veins to get isolated and to get durable isolation. Actually, if we have that kind of amount of contact, we have no problem to apply 15 watts. So please switch off 15 watts. And then immediately when we are going to less contact with the trachea, so we can just switch to the other mode. Okay, so
Do you
guys.
also comment on circa position or
Actually,
circa monitoring?
for all, I did already. So, and I can repeat it, for all patients we do for laser balloon ablation, every single patient, we have temperature monitor in the esophagus, and this is really like, it's AP position, so it's actually a very neutral position, like center position of the esophagus. So we didn't heat on the left side, and actually we are happy because we probably couldn't heat even from right side. So let's go. So actually I will start right now rotation, and you will see right now the starting point. Okay, so start the application. The laser is on, so the table indicates clearly the seconds I applying, and actually you can see that timing and the laser beam. Actually on the right side veins, you can sometimes even visualize the blanching under the beam. Actually in any single spot, you apply by, for example, 2 seconds, and actually the beam, the rotation of the beam is very nice to. Okay, so now we can change for 13, because I really don't want to burn too much. And actually what I would like to say, when I interrupt, I'm always going a little bit backward to get continuity of the lesion. Actually, what is very highly advantage of this system, that the rapid mode, so-called rapid mode, really allowed you to take all the circumference of the vein. Actually, what I need to say, we have chosen for you, for the live case, the worst vein actually in this guy, because all other veins were much better in terms of contact. So I really want to show you the ability to rotate and to treat all the veins regardless on the anatomy. But actually, you can just see that the laser is coming on the actually the anterior. We have still capture of phrenic, so we pass the superior part of the vein. It's coming to the bottom of the vein, and is now like 62, 63 seconds on the second part of the application. And we are going to be able, I hope, to ablate under the shaft. So I will stop right now, and let's check if we are going where we are going with this beam. Okay, so I will go a little bit closer. Okay, let's see what we have here. Okay, so we can really go under the shaft. So I will stay here very close, and then I can just by the bottom manipulate like proximal and distal position of the laser beam. Okay, so let's continue with 13. So it's automatic starting. So now the beam is going around. Actually, this is a 30 degrees laser beam. Now under the shaft is usually like some like time to not seeing anything, like when you go to atmosphere and you have some connection interruption, and Apollo 13 was visible. When I see the movie, I was a little bit thinking about this. So actually now I'm adapting the laser beam going a little bit closer inside to catch the good area of contact on the posterior wall of the left atrium. And actually now I'm going around, and I need to finish this 59, 60 seconds of non-visibility of the lesion, and now I'm coming back over the shaft and over the vein. So I will apply a little bit more, but actually we start here, so we finished this circumference of the vein nicely in 3 parts of the rapid mode. And actually what is really visible from the X3 study, actually we did with Boris Schmidt together, it's really with increasing patient numbers, we were able to treat more and more veins with the rapid mode only by one single circle. So right now we are ready for saying the true, and Honza is putting
deflating the balloon.
Actually deflating the balloon. So can you just show on the floor briefly? Okay, nice. So we are out of balloon. So what I like to do, because it's a little bit safety, so I really want to suck from the shaft and from the sheet back. Okay, don't do it too fast. Okay, be careful. You need to be careful about air embolization. So it's exactly what Petr Peichl said about all these big sheets. So you can get very nice energy or technology without any charring, without anything. But actually by the sheet manipulating, you can clearly get the small strokes or big strokes when you don't manipulate properly. So actually now it's time to saying true. We did, actually I must say that we did all the baseline checking of the veins. So can we show the baseline measurements from the Prague guys or not? We are not able. Okay, so because of this guys, the technical staff is not able to adapt our one-off screen, recording screen to the system. So we just can show you what we have as a current lasso or circumferential catheter recording. So now Honza is in left superior vein, which is clearly visible on
This should be the
eyes.
far field.
So actually, can they show even like eyes or not? I don't know. I don't know. Maybe this. Actually, just to visualize how far we are, or how inside or outside we are in terms of the level of isolation. Because when we remap all this laser Excalibur or X3 patients, so we were so amazed how far we are in terms of the level of isolation. Okay. So right now we are in very
this is the
like osteo part of left superior, and actually let's go for the left inferior. Okay, again 0, like
so left inferior is perfect.
So left inferior is isolated. Please go to the right superior. Okay. And
this is
0,
inferior. This is the inferior one.
So it's inferior. It's okay. Go. Can
this
show
is the eyes picture. Okay, that we are definitely in right inferior.
Okay, it's the right inferior vein very nicely visible, and there's no potential. Okay.
Okay.
Okay. Okay, and we have still some potentials on the right superior.
But it's very far field, so should we maybe try to pace from...
So can we justify this far field or the real stuff? Can you show me at least the baseline?
Zastavme prosím CS1-2. So let's pace CS1-2 just to exclude this far field from...
right superior, right?
Right atrium.
It's signal at the beginning of the P wave, so...
Can we pace CS1-2?
It's very early. It's potential.
CS1-2 pacing.
I mean, this should be real.
Can you pace faster?
Okay. How much how much output do you have? Okay, I think it's real.
So this should be far field. Yeah.
So.
That's good.
Okay. So, guys, what do you have? So actually, we are going to move to other lab. So, do you have any questions, Pepa or Robert, about?
How often after ablation you must go back with a balloon if there are one vein or more veins are not isolated?
Actually, it's very good question. We like to go with the same balloon. So actually, the touch-ups with RF. Actually, if you follow this all studies we publish, and actually Boris is very active. So Boris published. So the touch-ups are very infrequent. So we try to get with the laser. Actually, these are the veins. Usually with early branching, because there are some tricky anatomy when you cannot adapt properly. It means so-called early branching is one of the example when you have really tricky time to get good contact and good lasing. When we adapt the balloon and we are using, for example, the less energy we can, which is here 5.5 volts. Usually it's proved by preclinical series of animals. I did some, and actually Vivek did some. So we proved that the 5.5 volts you can apply even to the floating blood without any fear to get any thrombosis or any charring on the balloon. So actually, usually when we have troubles with esophagus, we have sometimes problem to isolate the vein when we play, and actually we are limited by positioning of the laser beam. Sometimes we need to go too much inside, sometimes we need to go way outside to avoid all this esophageal heating, because our cutoff limit, or the upper limit, is 38.5 for laser, 39 degrees of Celsius. Okay, so this is actually this is my answer.
Okay.
I don't know if you are satisfied with that.
Yes, very satisfied. Yes, very satisfied.
Okay, thanks. Actually, some other. So actually, is Joseph there? Is still?
No, I'm still
Joseph
here.
is still there.
Yeah, I must say
Okay,
that.
perfect. So do no. Wait. So, Peichl, what do you think when you ask me about the laser, the future of the laser? Because I think that it was a very straightforward question. So, actually, what do you think about this area? Okay, laser application plus this visualization.
I must say that it's much faster than it used to be when we did the first studies with this technology, but still it requires certain adaptation and I don't know how expensive it is also. So I feel
it's actually
that
the same price as a cryo. The
Yeah.
same price as a cryo.
cryo is faster, definitely. So I don't know.
But actually, with cryo, you cannot adapt. You need to have you have no proof about the contact, right? So it's sometimes tricky, and actually, there are not too much variables you can apply. In the laser, you can just really go bigger, smaller. You can adapt the positioning.
Okay.
You can adapt.
As I mentioned during discussion, at the end of the day, there are several technologies. At the end of the day, it will be which is faster, safer, less expensive, whatever. That one will be winner.
So okay, fine. I'm not promoter of laser. I'm not promoter of anything. So I just try to get the patient treated. And actually, we all know that actually there are a lot of patients with atrial fibrillation. Actually, if we have some safe technology, we can really treat them very early. I mean, we know that we have a lot of data right now and very robust data that we actually treat the patient as early as we can. It's much better for them. So I completely agree that actually it's a never-ending process, I guess. Okay. Yeah. So this is one of the examples how you can adapt the very original technology since 2000, whatever, 3, 4, 5, to a little bit. I mean. Reliable technology, but actually there are energies they cannot beat physics. Okay, so they are the physics is the limit. Okay, so you can ask differently. Actually, you can ask why, when we know that electroporation is so good, why we didn't adapt the electroporation much earlier. Okay, why we have electroporation right now in the clinical practice or in the clinical research.
I can answer you. I think everything has some development, and clinical practice will show clearly what is really the best or what is better, and people will adapt it very quickly. Believe me.
No, I asked him before because actually in radiology, electroporation is very well-known energy, and a long time, it's like 10 years ago. Okay.
Radio frequency was also used by surgeons for many years and then was adapted later for ablation. So everything has some development.
Okay, fine.
Okay.
I cannot disagree. I'm glad that we are part of this development.
Okay.
Yeah, me too. I think this is the most exciting, let's say, period during our life. We enjoyed being in this business for the last 25 years, and we could observe all this development of technology, development of treatment, success rate of ablations. I think this was a very nice period, and I'm glad that we all were part of this process.
So thank you very much for this nice case.
So we can move to the other room, okay?
Yes, thank you.
I
thank
hope
you
that
very
they are
much.
ready for the nice stuff.
It was a very nice demonstration. Thanks a lot.
Thank you.
All right, are we back in this room?
Yes, indeed.
Okay. Hi, Joseph and Robert. I see both of you. Do you guys hear us?
Yes, sure.
Fantastic. So what we have here today is a patient with paroxysmal atrial fibrillation and atrial flutter, it turns out, who we are going to treat with the Farapulse catheter. Now, this is actually, I guess the system received CE mark about a month ago or so, and so this is a commercial case. It's not part of a clinical study. So maybe we'll just introduce the technology. So if we look at this, this is the catheter tip right here. Can you zoom out a little bit, please? Zoom out. Okay, that's perfect, right? That's perfect. Okay, so this is the handle. Why don't we let's go to a basket shape. Okay, that's good. Stop right there. Go to a basket shape. Okay. Are we frozen? I can't tell. Okay, basket. Let's go basket. Yeah, we have to. Okay, there's some delay. Okay, fine. So there's a basket. Hopefully you see that. And then if you go further, it goes more like a biscuit type of thing. And then let's go all the way. And this is a. This is more of a, where is it? Let's put it this way. So this is a flower shape. And you can see the wire. We pull the wire back. You can actually touch to do flat ablation. Now, in this particular case, we're not going to be doing posterior wall. This is a patient with paroxysmal AFib. So let's go back to a basket, and then we'll go straighten it out again. Straighten it out. Okay, all the way. Let's pull the wire back a little bit. So that's the catheter itself. There's also a deflectable sheath. It's a 12-French deflectable sheath. If we can show this, please. The standard deflectable sheath, nothing terribly exciting. The one thing that's really nice is this shaft, as it turns out, is somewhat transparent. So as you advance it, you can look for things like bubbles, etc. So I actually like that about it. And then there's actually the system itself. Can you guys, is it possible to turn this thing around? Nah, it's hard. Can you bring the camera around so they can see the system? I think it's probably worthwhile. This is like, forget it. It's not worth it. Forget it. It's not worth it. Okay, let's go back to this. So when we introduce this, let's go back to live camera, please. Stefan, live camera. Wow, you guys have a quick response time. Okay, so I just want to point this out. I know this is somewhat mundane, but I think it's really important. When you're working with these large sheets, as you know, there's always the possibility of entraining air into the system. So the first thing we want to do is to keep the sheath down a little bit. And then we'll advance just to here. Now aspirate here, please. So we're going to aspirate because we want to get rid of any bubbles. Now we're going to give forward. So as we advance the catheter, we like to give saline so there's no air that's being entrained in the system here. Okay, stop there. That's good.
Okay, be careful about
And then
this.
so let's advance the wire a little bit. Okay, so here's the actual. Okay, so here's the actual catheter. So are they seeing on fluoro? No, show them fluoro and ice, please. Can we show fluoro and ice? Okay, great. So you see here, so all we've done at this point in terms of left atrium, we did a transeptal. You can see approximately where the transeptal is. There's the left pulmonary veins over there. And so what we'll do is, let's see, we'll advance here. There's the wire going into, it looks like the left superior pulmonary vein probably, yeah. Okay, and on fluoro you can see we're exiting the heart shadow. Notice, by the way, so the sheath, no, hold on, don't open yet. So the sheath is right there, and then there's a little marker just beyond the sheath. That's on the catheter itself. Hopefully that's very clear. So you want to have the catheter tip beyond the tip of the sheath before you open. So I'll put it back a little bit. Let's go ahead and open to a, we'll start off with the basket shape. Okay, so there's 5 splines here, as you see. Now, there's 5 splines and there's 4 electrodes per spline. The third electrode back is the one that's electrically active. So if we show electrograms for 1 second, and you'll see this patient is in a flutter-like rhythm, you can see 5 electrograms, which are the ones in green. Well, I don't know if you can see the color, but the 5 ones that are in the middle, it says FAR 1 through 5. Those are between splines. So they're somewhat far-fieldish, but they're still quite helpful. Okay, let's go back to the fluoro and ice, please. So let's see. We'll make this a little bit bigger. We advance, so we're touching. So here, if we look on ice, I'm going to show the ice because a lot of what we do is going to be based on ice. It's not the best ice image, but let me give you a better view, hopefully. So hopefully you can see the ice over there.
Yeah.
Okay, good. So here's fluoro. Just show fluoro and ice, please. Yeah, fluoro and ice, please. Yes, thank you. Okay, so there you see the position based on fluoro. And notice on fluoro, I have two splines up. One spline up. Let me do this way. So one spline up and two splines down. I like to pay attention to that because what's going to happen is, and I'll just fluoro for a second again, because then after we make our lesions, when we rotate, then we'll go to one spline down and two splines up. All right, so let's go ahead. Let's get ready to do our lesion. What we'll do is let's show the electrograms and yeah, good. So again, on the electrograms, you see of course the surface EKG. You see the 5 electrograms of the basket catheter, and then you see the CS on the bottom. So we're going to go ahead and do the application. So let's charge, please, or whatever. Okay, here we're going to go 5 applications. Here we go. Go. And there, the vein is isolated. So it goes pretty quickly. Let's do a second application, please. Can we give some propofol, please? It's interesting. So the patient is actually coughing a little bit, and we see this now and then. So I'm going to do a rotation here. And I don't really fully understand. Okay, let's go ahead and do another application. So we did 2 sets. Yeah, go ahead. So we did 1 set of applications. Then we do, and each set you see is 5 pulses. So that's 1 application is the 5 pulses. We have to wait about 7 or 8 seconds in between, and then we deliver the next set of pulses. So we did basket 2 and 2. Then what we're going to do on show fluoro, please. Fluoro and ice. Fluoro and ice. Okay, great. So now what we'll do is I'm going to go to full. So this is now the flower pose, and so we're going to push that up. Let's see. We'll do it. Maybe what we'll do is we'll have it this way. Yeah. Okay. And notice now, if we show the electrograms and ice, please, you see this now electrograms again. And the reason is because we just made this wider. So the first set of lesions is there to isolate the vein, and the second set we're going to do it to broaden the level of isolation. So let's go ahead and actually hold on one second. Yeah. Okay, so let's go ahead and broaden the level. Okay, let's do another. Well, actually, show them the electrograms. Okay, good. Go ahead and another lesion, please. Okay, and again. So again, we have to wait 7 or 8 seconds in between each application. Go ahead. Then on fluoro, go fluoro and ice, please. So I'm going to rotate, and then we'll do another set right here. Go. And again. Okay. And so that's it for the left superior. Now, let's wire back, please. And then let's go wire again, please. Okay, let's go to basket. Okay, so now we're going to do the left inferior vein. You can see on ice that we're back. You want to go ahead and put it down? Yeah, yeah. You can see right there on ice. We engage the left inferior. And if we look at the electrograms, can you show the electrograms, please? Okay, great. So you'll see the electrograms there. So let's go ahead and do another lesion here. So go ahead, please. And then. So again, the first lesion typically isolates. By the way, you still see this, these low frequency electrograms, right? And that's, again, remember, go ahead and keep going. Don't wait for me. If I keep talking, we'll never deliver any lesions. Okay. Okay, fluoro. Okay. All right, then, yeah, go ahead, ablation. Anyway, I was just going to say the electrograms are a little bit far-fieldish. And again, because these are big electrodes, so don't forget about that. So after this, we're going to go to the flower pose. So fluoro again, please. Okay, let's go on there, please. Toshi's going to show you ice here. Okay, go. Okay. No, that's, yeah, good, that's better. Okay, and then let's go over here. So I just rotated and re-advance, and we're going to do another set of lesions. And then we'll do one last one in just a second. Okay, so now we're done with the left side. Okay, let's go ahead and, oh, actually, you know what? Let's do it this way. So we're going to bring the wire back, not almost all the way in. And with this, I'm going to take this, and then basically we'll rotate around till we get to the right inferior vein. So let's advance there, please. Wire in slowly. Yeah, okay, that's good. So we're in the right inferior vein, and here we go. There's the petals. Okay, so let's show them show them ultrasound and fluoro, please. Fluoro ultrasound. Okay, good. So yeah, there's the catheter at the os of the left of the right inferior pulmonary vein. So I like that position, I think. So let's go ahead and show them the electrograms, please. Electrograms and ice. Okay, let's go ahead and deliver lesion here. You guys, can we get a propofol, please? Yeah. Yeah, go ahead. Okay. Okay, so, okay, wire back. Okay, good. And then we typically like to rotate a little bit, advance the wire gently.
So you started here with flower,
okay, perfect.
Vivek?
Yeah, go ahead.
You started with flower here.
Yep. Yeah, you can start with a flower or a basket. I just thought I'm already there, so I just decided to do it that way.
Okay. There is one question. How is it with ACT? But I believe that it's the same like for any AFib procedure. What is ACT level? Is a question here.
Oh, I don't remember. It's over 300. I mean, but we typically do whatever we normally do. There's nothing special.
We need to be over 300 when we introduce the catheter.
Peter's pointing out we want to be over 300 when we introduce the catheter, just like for any big array catheter.
That was my feeling that
it's
the same like for any procedure.
Yeah. Okay, let's go on here. Yeah, so exactly. It's the same for any of these procedures. We don't necessarily need anything more, but we don't really want less either.
It's interesting now on ice, I noticed that there was a shower of bubbles, or micro bubbles, let's say.
You see the micro bubbles, and in my presentation I pointed out that the number of micro bubbles. I'm sorry, let me just rotate first. I'm talking too much. The number of micro bubbles. Let's go on there, please. The number of micro bubbles is actually less than what you have with a single typical RF application.
It doesn't look from this, but
they're certainly there. I'm sorry?
It doesn't look from this picture because it's a real shower here.
I know. Right. No. It's highly refractile. You're absolutely right. But if you look at the size of the microbubbles, if you look at the number of microbubbles, it's dramatically less than what you see with other stuff. The difference here is it all happens within a few milliseconds, right? So that's the difference. Oh, hold on one second. Let me go here. Okay, let's go right superior. Yep. And I'm going to play the fluoro. Actually, let me do it this way so they can see. We're having a little issue with our fluoro system, as you see. So that's one of the problems here. Okay.
So the labs, they have no
So
eyes,
what I'd like
must
to
you
do-
angiography?
You know, we used to do angiography in the beginning. That's right, right? Long time ago. But we don't do that anymore. And we always use ice. If we didn't have ice, we still wouldn't do angiography. It's just not necessary, I think. Okay, so let's look at the electrogram. So this is the right superior pulmonary vein. Let's go electrograms and ice, please. Okay, let's go on there. Ablation. Okay, good. Oh, I have to rotate, I'm sorry. I lose track because it's so, you know, this happens so quickly, I forget what I'm doing sometimes. Go on again.
I mean, I must say that
So,
it's
again,
really
our convention-
amazing. It's really amazing how fast is the disappearance of the signals. So
Yeah.
how easy it is in general. I mean, it's amazing.
Yeah, you know, it's interesting. It's like this. What I was saying. It's so quick and easy that it's very seductive, and it's hard to not believe that this is going to be part of our armamentarium in the future. You know, I'm sure this is what we're going to be doing for most of the paroxysmal patients. A lot of us.
I strongly believe.
Okay, so now we'll do the flower. Let me see. Maybe we'll go. It's actually more of a forward flower. It's a little too far, I think. Let me go this way. Yeah, like that. Okay, so where are we? Yeah, still there. Looks good to me. Maybe I'll go a little more anterior. Okay, let's do that, please. Let's show the fluoro also so people can see where we are. The fluoro nice for a second. Okay. Let's go here. Yep. Oh, looks good. Yeah, go ahead. Okay, so let's terminate this flutter for a second because he's going 1-to-1 and there's some like respiratory issues or something. Are we okay? Yeah. I thought he wasn't intubated. Oh, you had done a mask thing. Okay. Okay, I got it. Go ahead. Okay, so we're basically isolated. That's pretty much the end of the PVI part of the procedure. Obviously, he's still in this atrial tachycardia rhythm, so we have a little bit of work to do. It's what? Oh, yeah. Oh, so that's cool. Okay, so this is, they have on the screen, why don't you turn it around so they can see? Basically, from the beginning of the first lesion to the end of the last lesion was 11 minutes. So it's pretty quick, as you can tell. So, Joseph, you guys, can you see that?
Yeah, we are astonished. We cannot say anything.
It's really fast.
It's very striking, isn't it?
Yeah, it is.
So what we'll do now, let's put this thing back. What we're going to do now, so normally in a regular clinical case, we can go to camera, please. In a regular clinical case, we would just stop the procedure. Camera, please. So normally we would just stop the procedure, but in this case, first of all, he's got this atrial tachycardia, which I'm going to deal with right as soon as they finish intubating the patient. And then second, as part of we're just trying to understand, level of isolation, other things. So we're going to be doing some electron anatomical mapping. We did do a baseline voltage map. So what we're going to do, I think, is while they're intubating, here, I'll move forward for you. While they're intubating, I think what we'll do is maybe we can go to the, Oh, the recorded case. Okay. So I think what we'll do, Joseph, it's okay. Well, actually, first, are there questions in the audience? And let's deal with those first.
I don't think there is any. Oh, there are maybe a few. Well, let me see. What is the percentage? The percentage of post-ablation associated atrial tachycardias in contrast to conventional RF PVI?
Oh, that's a good. I don't think it's any different. And again, just to be clear, this tachycardia was there from the beginning of the procedure here, right? This is not separate. It is possible, though, I should point out, when you have, let's say, a small atrium, you can get the roof lesions on both sets of veins to be so close, you could leave an isthmus in between. And that's certainly something, I remember we saw that once in the clinical study. We haven't seen any potentiated mitral flutters, but I suppose anything can happen.
There is another question whether it's possible to use a chief catheter through the ablation catheter to check the potentials in the vein. Well, there are no potentials in the vein, but you can answer.
It's, maybe, I don't know. I guess we want to increase the cost of the procedure. No, I shouldn't laugh. It's not a bad point. I got to say, though, with pulse field, everything disappears so quickly and easily that I think once you start doing it, you realize there's no point looking for these things. I mean, the reality is you have to wait till the patient comes back if they have a clinical recurrence.
Yeah, that's what we discussed during the debate. I think it's very important to notice that there are no signals, so you have to check after 3 months if you want to see what is the durability of lesions, or you have to wait 1 year or so to see the long-term efficacy.
Yeah, exactly. Absolutely. But I guess technically it should be feasible, right? There's no reason why we couldn't put in a chief catheter through here.
Yeah, but there will be nothing.
There's another technical questions. What's the configuration of pulses? Do they travel between each of consecutive electrode or between each arm of the flower catheter?
Yeah, it is bipolar and biphasic also, but it is bipolar, so it's going between the electrodes in some complex fashion that I don't know. Basically, that's a trade secret that the company hasn't divulged. And I really mean it. I don't know. They won't tell me.
Did you use a 31 or 35 millimeter device size for this case?
Oh, this is a 35. Yeah, this is a 35 millimeter. 35 is our go-to. Unless somebody has a very, very, very small atrium, we always go with the bigger one.
There is another question whether you can make a linear line CTI with the catheter straightened.
Yeah, I mean, straightened? No. If you straighten the catheter, in fact, the system will prevent you from delivering because all the energy just shunts in between. You'll get nothing. Now, if you put it in a flower and then try to put a lesion, the problem is you probably would get the CTI, but you get everything else in the area. So I don't think that's something you'd want to do. Not with this catheter. No. I think what this catheter is really good for beyond PVI is the posterior wall. I mean, that works beautifully well because you saw how the catheter can sit on the posterior wall. And when we did that in the persistent trial, Persephone, we had electron anatomical mapping so we could see at least those 5 electrodes. But reality is that I think even with just fluoro, you could do the posterior wall pretty quickly and easily.
Yeah.
On the left side, why do you start it with a basket, not with a flower at the beginning?
Yeah, I typically start off with the basket in most veins and then go to the flower. The idea being use the basket, verify you've isolated the vein, and then the flower to bring the level of isolation further back. That was the conceptual strategy. In the right inferior, you're right. I just started with the flower because, well, it was already there and it was easy enough to do it. But you'll notice that in the superior, I started off with the basket. And I didn't point it out, but when I did the superior, I started off with a bigger basket than most of the other veins, just because with ablation, I didn't want to fall inside the vein and end up too far inside.
There is a provocative question, Vivek. Isn't this case an example of what will be experienced or what we will experience in the future when interventional cardiologists start the use of PFA, treatment of flutters with PVI?
Well, so there's two parts to that question. The fact that the questioner said interventional cardiologist, I mean, I guess I'll replace that with, I guess, a less experienced operator, let's say. Because honestly, I don't think it matters whether it's an interventional cardiologist or an electrophysiologist, but somebody that knows how to do that. But let's say that happens, and let's say that, yes, there will be some atypical flutters. That'll happen. It's the same thing that happens when you use a cryoballoon. I mean, you'll have some atypical flutters that you don't get with it. I don't see what the issue is. If the point that if the question is trying to make is that when you use a one-shot technology, you're not able to get atypical flutters, you're absolutely right. That's a downside of a one-shot technology. And that's where catheters, systems like the Affera system, you know, have real efficacy and the flexibility. The flip side is, for every one of those patients, there's probably 50 or 60 other patients who all you do is this in something around 12 minutes. And then you're done, the patient's done. You can imagine a very early discharge. So I don't think there's a perfect answer for everybody. I mean, so let's say everything was approved 5 years from now. We may look at this patient and say, hey, this patient has an atypical flutter in addition to, obviously, paroxysmal AFib. And we may decide to start the procedure with a focal catheter, like a lattice or something along those lines. Or we may look at a different patient who has just paroxysmal AFib and say, let's just use a one-shot technology, whether it's this one or something else. So I think that saying this technology is good or bad because it doesn't help everybody is not necessarily appropriate. I think it's more appropriate to say, for this kind of a patient, we have these options, and for that kind of a patient, we have those options.
Yeah.
Okay, there is another question. Is this catheter suitable for mitral isthmus ablation?
Yeah, again, look, I think actually Pierre did one case like that where he took this and put it in the mitral isthmus because the patient had mitral isthmus flutter or something. And it certainly can be done. It does make really good lesions. But the problem is it will be a big whopping lesion. I mean, it's one thing to have a whopping lesion that's a channel because it's a really, really safe technology. But to have a whopping lesion that's also spreads left and right means that you're going to take out a lot of myocardium, right? So I'm not a big fan of the idea of using this for mitral isthmus ablation. And frankly, it has not been studied for that.
Another question is whether you can make 3D map with a Farapulse catheter connected to EnSight.
Yeah, it's a good question. So you can. It's not the highest quality map because you basically have 5 electrodes, right? And that's it. And the system wasn't optimized for that. So you can do it. We have done it. It's not the highest quality map. Presumably, at some point, either the company or whoever acquires the company will put a magnetic sensor in the tip of the catheter. It actually already has space for the magnetic sensor and everything, so it just needs to be done and then connect to a mapping system. So my guess is that that's going to be what we'll see in terms of its incorporation into mapping systems. Is that necessary? Well, I think you saw that it's not necessary for this case. I think it could be very useful for decreasing fluoro exposure and that kind of stuff. By the way, talking about fluoro exposure, so before you came on, I told you we did some electron-anatomical mapping and some other stuff, and right now we're at 6 minutes and 46 seconds, so it's not a terribly high fluoro exposure. That includes all the stuff we did before.
There is another question. Is there a different pattern of AFib recurrence in blanking period?
Oh, it's a good question. I can't say that I can answer that scientifically with any data. I can tell you that my gestalt is that we don't seem to have as much early AFib, which makes sense, right? Because there's good data that early AFib doesn't necessarily mean you'll have eventual AFib, but it does increase your chance of having it. So, but I do think, though, that, look, this is still ablation. I think there's still inflammation that occurs, and I'm not sure that all of that stuff is going to disappear.
Okay.
There is one more. Can you put the catheter inside the PV?
What do you mean? I'm not sure I understood the question. We did
Well,
put the
this
catheter
is
to
a
the
question
PV.
I just received from chat. If you can put a catheter inside the PV,
Of course you
you
can.
showed nicely that you just embed the catheter in the ostium or antrum of pulmonary vein, and then covering with flour a bigger area. So obviously you can go inside the pulmonary vein, but there is no point to ablate inside the pulmonary vein. Huh?
Yeah, you can. Now, maybe what the... Yeah, I don't think I can say much beyond that.
Yeah.
Yeah. I don't see a great advantage in it. It is true, though, maybe the question was on safety. Look, the data, I think, is really strong that you don't cause any PV stenosis or even PV narrowing. So I think in that sense, yeah, that it's not a problem at all to be inside the PV. Maybe that was what the question was directed to.
Yes.
So I think that, you know, we're going to map this thing and deal with this. But in the interim, I think what we'll do is we'll go to the recorded case, right? Okay, so why don't we go to the recorded case? As it turns out, it's going to be a little bit redundant from what Petr Peichl did, which was a very nice recorded case. But that's okay. You'll see a slightly different perspective and maybe see, well, you'll see a different case. So why don't we go ahead and play that? It's a lattice tip catheter that we did, I think, about a year ago or sometime. I don't remember exactly. And then maybe we can come back here after that. Does that sound okay, Joseph?
Yeah,
Yes.
that's fine.
Okay.
This is a patient with paroxysmal atrial fibrillation treated at Homolce Hospital. Now, before getting started, let's take a look at the catheter itself. It's a typical focal catheter with a 7.5 French shaft and a tip that's 9 millimeters in diameter and compressible. So it can actually be advanced through a standard 8.5 French sheath. It also has an interesting surface topography that increases the amount of friction in order to increase catheter stability during mapping. You notice it's also bidirectionally deflectable, and these controls on the handle that allow basic operations such as start mapping, stop mapping, etc. Now here's what the catheter looks like under fluoroscopy. Here's the ICE catheter, standard CS catheter, and the lattice catheter advanced through a deflectable sheath. Now this is linked to a mapping system. You can see here the electrograms that are on the surface of the catheter, the mini electrodes. These are the CS electrograms, and this is surface EKG. As we sweep this around within the chamber, we can create both the geometry as well as annotate it with the electrical information. And here what we're creating is a voltage map. So this is a posterior view and a top-down view as we move from the left vein. So here that was the right inferior pulmonary vein. Then we move anteriorly to the right superior pulmonary vein. And then here we'll jump forward again. Most of the chamber is created here toward the mitral angular region. One of the things you notice is the system is quite good at creating invagination. So between the left pulmonary veins or anterior to them, the appendage and the left atrium proper, you can actually see this invagination created quite nicely. So now we're going to go ahead and get ready to start ablating. So we'll start off with PF lesions. Notice the electrograms pre-ablation, and then there's a small amount of heating, very little heating, Julic heating that will occur when we go on with ablation. Not enough to cause any thermal damage, but as you'll see, it is useful to help us know that we've actually touching tissue. And notice the electrograms disappear very quickly. And you notice that the pulse field lesions are about 3 to 4 seconds long. Now, once we create the first lesion, the next lesion we're going to create, we want it to be about 5 to 6 millimeters away. And this distance helps us. This is the distance from the centroid of the catheter to the closest adjacent lesion. And what you see here is these gray bars that are connecting the two. So the system knows which are the most closely adjacent lesions. Notice that on the posterior wall, oftentimes you're ablating right on top of the esophagus, as you see here on ICE imaging. And this is not uncommon at all, but we've never seen any damage to the esophagus with PF. Now here's an interesting point. We make a lesion here, but notice that this connecting line is actually blue instead of gray. This is an indicator to the operator that the distance is greater than the 5 or 6 millimeters. And again, this is a user-defined definition, so you can move this or change this to whatever you want. So we're going to create PF lesions posteriorly, but as we get anteriorly, we can actually switch to RF. So just by simply switching clicking the pedal, you can switch from PF to RF. And what you'll see during RF, because the temperature goes much higher, you'll see a blush of red on this thermal response. So you can see quite red as the lesion is being made. And we're going to rotate this around, and here again you see the top-down view. The distance here again is to the previous lesion. Here, between RF lesions, we like it to be about 6 to 7 millimeters lesion to lesion. One of the interesting things is notice that this is a much larger thermal footprint than a standard catheter. So that's able to both enhance lesion depth as well as better chance of having lesion contiguity. So we're going to keep making lesions as we come up here. Notice as we come up here, we make our last lesion, and even though there's a gap, we oftentimes see electrical isolation with this gap. So here we'll move the catheter inside, and sure enough, the vein is electrically isolated. Move it back here, you see a catheter-induced potential, but then it's electrically isolated. Now, despite that, we don't want to stop there. We always like to close the electrical gap. And so here, we're going to place the last ablation lesion in order to electrically isolate. So we did PF posteriorly, RF anteriorly for electrical isolation. Now let's move on to the left side. Here's a PA view and a top-down view, and we make our first PF lesion. I'm going to keep jumping forward and make a series of lesions as we come all the way down here. Once we get to the bottom, then we'll switch to RF and then deliver RF lesions all along the ridge till we come up here superiorly to electrically isolate the left pulmonary veins. Once we place our lesions, we can move inside to verify entrance block, as well as we can pace from inside with the catheter itself to actually confirm exit block. We also give adenosine to verify that block is sustained with adenosine. Now, this is a patient with paroxysmal AFib, so we stop the procedure in the left atrium right here. But if the patient has persistent AFib, we oftentimes will do a mitral line and a roof line. Now, this is from a different patient, and here you see a mitral line with block after PF line, and here you see a roof line, again with block. But again, this is a patient with paroxysmal AFib, so at this point, we pull out of the left atrium into the right atrium. And what you see here in the right atrium, here's electrical potentials. This is the RAO view and a bottom view. Notice after the single RF lesion, the electrograms are abrogated. So then when you pull the catheter back a little bit, you'll see that the electrograms are already splitting. And here you see the lattice tip very easily seen on the CT isthmus here. One of the other things that's nice about the catheter, particularly for a CTI, is the topography of the back end of the catheter. So what you'll see as we bring the catheter back, you can see the back end of it will actually end up heating. So if we look here at this bullseye, this is the tip, the distal electrodes, and the proximal electrodes. And you see the contact shown in white here. This is the electrical impedance-based contact. And then we deliver the energy and the heating right here in order to achieve conduction block. And what you'll see here is the catheter. We're going to move this laterally. And once we move it laterally, you see the time from stim in the CS to this is quite long. Now, one of the last things I want to show you is the actual outcomes here. So we conducted a 3-center study of 76 patients with paroxysmal or persistent AFib. You can see for PVI, the energy delivery time was quite short, about 3 minutes, and the transport ablation time, defined as the time from the beginning of the first lesion to the end of the last lesion, is only about 23 or 24 minutes. For the linear lesions, it's even better. You can see the energy time is minutes to seconds, and the transport ablation time for the mitral line is 5 minutes, and for the other lines, about 2 minutes. Similarly, the fluoroscopy time is quite good at 5 minutes. Now let's look at a few other cases. So here's an example of a patient where we did PF posteriorly, RF anteriorly. You see the pre-voltage map and the post-voltage map. Here's another case. Again, you see anteriorly over the right pulmonary veins, posteriorly PF. We've also ablated a number of patients using both PF, both posteriorly and anteriorly. And you've seen this case already with the mitral line and the roof line. And here's another example, PF posteriorly and anteriorly in a posterior box lesion set. Our experience with the lattice catheter has been quite encouraging in terms of the acute ablation procedures. But of course, there are important questions. How durable are these lesion sets, And how does this translate in terms of clinical outcomes, in terms of freedom from atrial fibrillation or atrial flutter? And these are the questions that will be answered with additional studies. Do a voltage map, please.
Okay, so we are back.
Peter, can you talk?
Andrzej.
Peter?
Okay, yeah.
Yeah. Is he on?
Okay, guys, so can we answer some questions? So what is different on this procedure between Petr, Peichl, and Vivek's?
It's the same. Re-register.
Pepo, Joseph, can you hear me?
Yeah, I think
Yeah.
It was just another
it's
case.
the
So
same
have you
system.
have you seen any differences?
This was shorter.
No, it's cut.
I
It's
know.
not fair. He's not so fast.
I know.
He's not so fast. Actually, Vivek needs to work on this, the mapping of the, actually, hopefully, atrial tachycardia.
Show me
So
left lateral.
actually, we have some
Left
options,
lateral.
okay? So we can discuss something, or we can wait for this mapping, and we can discuss the mapping here, or we need to have a break to just finish this, and or jumping to the last our case if
AP.
you are interested to show the appendage closure with Watchman Flex device. So,
Re-register.
so just guys, you are chairman, so tell us what we should do.
So you can do now the appendage closure in between when Vivek is mapping, or?
Yeah.
Yeah, we could do that.
Oh,
Okay.
Then let's go.
Okay.
To save some time,
Great.
and it's almost 8 o'clock, so we can see the closure, and
It depends.
then you can finish the case.
It depends how many cases you have for this evening.
Yeah, okay. You want to go ahead and get going? Toshi, you want to come here and map? Okay, good, perfect. Can you re-register? Good. Wait, this isn't right. The purple is like all the way down here. Oh, I never went into the right inferior vein, that's why.
Can we see what you are doing now? Can we see the map? Vivek?
What kind of mapping system you have?
Oh, I'm online? Oh, boy. Oh, sorry.
Now, the question is, what kind of mapping system do you use for this mapping of tachycardia?
Yeah, so this is a Cardo system. I know they're all looking the same nowadays, but this is actually the Cardo system, just a standard Cardo system. And as I said, we're doing a voltage map because we're just trying to, well, get some data. Show me an AP view, please. So, am I supposed to go next door while Toshi is here? Oh, okay. I'm sorry, I'm going to join you guys next door. Let's see here. I'm going to need another coat, or another. Okay. Is the camera not working in here? So, can you, oh, you are?
Yes.
Okay. Robert, can you hear us here?
Yes.
I don't know if they can hear us or not.
Yeah, we can hear you.
Yeah, we do.
You guys can hear us, Robert?
Yeah.
Yes.
Okay, there. I'm hearing something over here. I need another gown, please. Okay, what are you seeing here? Are you seeing the fluoro and the
So can you
ice?
see El Floro?
I don't know what they're seeing.
No, we see
You see
Peter.
Peter.
We see Peter.
Yeah. So we have
Okay,
right
good.
now SL SL0 catheter inside, so we are proceeding. I'm trying to get, okay, here. So I'm trying to get the transeptal needle, and we are going for the transeptal puncture, which is really different than we are doing for all our AFib cases, because we need to figure the positioning, because we have really the advantage to use eyes only as a guiding for appendage closure. We are not using too much TEE. So actually for the puncture, when we have this the appendage closure patient, so we are targeting more anterior, or let's say okay anterior part of the septum, and we need to be very kind of inferior, matching the location of appendage position.
Okay.
So actually the question is, what is ready now? So we have TEE, and I hope that we can say it's what's chicken wing appendage or windsock appendage. I don't know.
You want me to do that? I'll do that while you
and
do it.
actually we have sizing of the appendage from the TE done several days ago.
So can you guys,
sizing.
Peter, can they see ice?
This is a big appendage, which is 26
We can see
in
ice.
diameter, and the length depth is 33. Okay, so it's and there are not any mentioned lobes. Okay, so let me proceed.
Can you guys see?
Ready this
Wait 1 second.
transeptal, and Vivek will show you how to guide the appendage visualization from the PA, I guess.
Can you guys see the ice image right now?
Yes, we do.
Okay, great. So this is the left atrium. Hopefully you see the left atrium at about 7 o'clock, right? This is a typical view from the pulmonary artery. You can see it's a little smoky in there. When I counterclock, I'm looking more anterior, and I can see sort of more distally and distally and distally. I don't see an obvious thrombus in there, but given the smoky situation, this is not an appendage that we want to go very deep. And I think it'll be nice because you'll see how with the Watchman, we're going to stay very shallow with the Watchman Flex and implant the device. The other thing that's nice is, here's the left atrium again. Looking at the ostium of the appendage, as I clock, meaning as I go more posterior, you see that there's no other lobe. So this is not an appendage that, for example, is a chicken wing type. So this is not like that. So while we tend to puncture anterior anyway, it's not as critical in this case as it can be in certain other cases. So now I'm back in the right atrium, of course, and you can see the interatrial septum. The septum is really bowing out away from the from where we are. So I want to really make sure I do a good job of putting a bend on the needle. So we still typically use just a regular, the regular metal needle. I don't know. It'd be interesting in the audience, Robert, how many people use just a regular needle versus using one of these powered needles, like an RF needle?
It's difficult to ask
What do you
this
guys
question.
use?
Well, we use the normal needle as you suggested. I mean, we made some bend on the needle depending on the size of the atrium, but we use just typically conventional needle.
Yeah.
Yeah. Oh, you know what? I think this is a little low. I was trying to avoid these wires. This patient obviously has the pacemaker leads, so we will have to be a little careful here. Let's see here. Yeah, there I'm certainly. I'm gonna take the wire up again.
Okay.
We want to make sure that we're avoiding the lead. Let's go a little LAO. I like to do most things in AP because it's just less radiation. But when there are pacemaker leads, it's worth doing a little bit of RAO. Or I'm sorry, LAO, not RAO. This is moving at a glacial pace, but eventually, hopefully, it'll get there. It's taking longer to go to LAO than it's taking to isolate the veins next door. Okay. So Yeah, this looks safe. Okay. So taking the needle up here. Okay. So let's see on ice. Hopefully you can see that. I'm going to come down a little bit. It's very low already.
Yeah.
I'm getting lazy here. So this is a trick that we sometimes use. You have to be very careful when you do it. If you see on fluoro, I basically pull the dilator back, put the sheath up. Then what I do is I pull the dilator up close and then withdraw the sheath over the dilator. Oh, we're hanging on to that lead. Yeah. Oh, that's better. Advancing the dilator again. Now withdrawing the sheath over the dilator gently, carefully. And let's see where we are. Let's see where we are on the ice. Still a little low, huh? It's very anterior, actually.
Yeah, very anterior now.
I was so worried about having enough bend. I think I put too much bend on this thing. All right, I advanced the dilator again, pulling the sheath back over the dilator. I think I should take some bend out of this. Well, let's see. Okay, where are we now? Still anterior, huh?
It's out, touching aorta.
Okay, there.
No, it's better.
So there we see it. All right, let's do that. Needles forward, push across, inject contrast. Okay. We spent a lot of time with the transeptal puncture, and the reason is because, if you do a good transeptal puncture, then the rest of the appendage closure procedure is easy. If you do a bad transeptal puncture, it's just a flog for the rest of the case. So it really is important that the one is very careful with it. So now we have transeptal access with the afferent sheath. We're going to switch over to the Watchman sheath.
We have it.
Do we have it, Peter?
We have single curve.
Okay, great.
There are two curves.
Let's go back to AP. We don't need to be in this anymore. Okay. So we're going back to an AP view. Okay, that's probably in the appendage. We don't want to be too far in there for too long. No, I don't want to be there. Okay. This thing does not want to go anywhere else. Well, you know what? It's okay. Well, let's just do this. Okay, we'll just exchange over.
Okay.
You got it?
Got it.
Okay. Okay, so we're going to just exchange over to the Watchman sheath. Remember that the Watchman sheath is a 12-French sheath. This is not a deflectable sheath, though we're hoping in the future we do have deflectable sheaths, because I think that actually could help for a lot of these appendage closure cases when they're challenging.
Okay, great. Okay, going.
Okay.
Jiggle.
Yeah, it's good. It's fine.
Bit slower. Nice. Take care about this.
Yeah, let me have this.
I mean, take care about your floor.
Oh, the floor. Oh, I thought you meant. I went in the V. That's okay. So the wire. Sorry, you saw that I pushed the sheath across a couple times. Then I'm going to pull it back into the IVC. And now, if you look on ice, can they see ice, Stepan?
Yep.
Okay, here it is. Let me just
we
see.
can.
Okay.
We can see
So
it.
there you see where the wire is crossing. So what I'm going to do is deflect toward this, rotate until I see this again. And yeah, that should be right about here. Not there yet. We're very close, but we're not quite there. Oh, there we go. So we just got across the interatrial septum. So what I'm going to do now is do a backward deflection and a rightward deflection. That usually gives us a pretty good view of the appendage. Of course, here it's becoming a little more challenging. Let me look on fluoro. Okay, so I don't know what's up with this ice catheter. Okay, there's a backward deflection, a little rightward, and there you see the
appendage.
I know. Okay, so we can get a good look at the appendage right here with the wire that just keeps wanting to go there. I'd rather put the wire in there. I just don't want to be inside that thing. Okay, so we can look at the measurements. What were the measurements on?
It's a 26
Okay,
diameter.
let's measure right there, please. Okay, freeze. No, let's scroll a little bit.
So good.
Keep going, scroll more. Keep going. No, back a little bit. Right there. Let's measure that one. And so we're just going to make a couple of measurements. That's probably a little bit further out than we need to be, but that's okay. No, more.
No, it's
This is, what do we get on TE?
26.
26? Are we sure?
Yeah, I know.
Okay, let's measure further in.
In
the widest part of this, because that's really too far out. No, in, the other way.
Okay,
Down,
so
down.
Vivek,
More.
it's 22.
22, that makes more sense. Okay. No, down, all the way down. Yeah, right there. More. All right, I can't make it any bigger. Okay, that's good. Live, please. Now, we're going to go, the other view that we can do is to enter this. So now I'm inside the left superior pulmonary vein and looking down at this. So let's measure right here. This is good.
Very nice.
Right there.
This is
Let's
very
measure
nice.
that one.
Okay, it's maybe bigger.
No, scroll. Keep going. More. Right there. So let's measure from there diagonally. Now up higher. More. Up. Right there. And then from there up.
Trošku
more,
nahoru, trošku nahoru.
More.
Ještě malinko.
Up. Yeah. So that's
Pojďte si
20.
očima.
Okay. Then let's go live again, please. And then the third one that we like to do is here I'm going to rotate till I see the posterior wall, which is right there. And then what I do, lock the ice, do a backward deflection, and then a little bit rightward. And what that does, hopefully, will show. See, we're right across the mitral. Here, let me just show you on fluoro. So you can see the ice. Actually, go do the high quality fluoro for a second. Sorry, we always do low quality just to decrease fluoro exposure. But you can see there, the ice is sort of tilted down. It's looking up at the appendage. So you can see like a boot there with the wires inside. Let me pull the wire back again. The wire just wants to go in there. So again, it looks the same to me in terms of sizing. Okay, so let's assume that the T is right.
So 24, 27,
I go 27.
27.
Yeah, we'll go
okay.
to 27 device. Okay, so now
Guys,
let's go
open
ahead
27,
and
okay?
get the 27 device. Meanwhile, I'm going to just put the ice catheter. Where is it now?
Okay.
Yeah, I'm going to put the ice catheter sort of in the left superior pulmonary vein again. So let's go in there. So now the ice is in the left superior pulmonary vein. On fluoro, what you're going to see, I'm going to push the sheath across. So now both of these are in the left atrium, both the sheath and the
Světlo trošku, okay.
and the ice catheter. So let's, I don't want to have a big empty space here, so we'll just leave this right about here. Okay, so we're just prepping the catheter.
So I get to the tip. Okay, close it. Okay, can we go? Okay, so I will suck.
We're just, it's always really important to get all the air out of the system. Okay, let's flush forward, please.
Okay, can I
Yep.
go? Okay. Super.
Okay.
Nice.
Dobrý.
One more.
Okay. This is contrast, yeah?
This is contrast.
Okay, good.
One more.
Okay, that's good.
And backward.
Yeah, I think it's okay.
Is it bubble? No, it's a bubble.
Oh, you wanted to push it out. Okay, go ahead.
Okay. No, I will close it.
One second.
I need to close it.
Peter, I just need to
close it.
push this back.
No, I need to. Oh, okay.
That's right. I just need to push this
That's
back.
perfect. Okay.
Okay, let's flush forward again, please.
1, 2, 3.
Okay, I'm going to flush forward, please. Great. Okay. Okay, so let's take this out, please.
Světlo. Okay.
Okay, so we'll put the device in. How much time is there, by the way? I want to make sure we have time for everything.
8.
Oh, we have 6 minutes? Okay, I think we can make it work. Okay, so the device, can I have some saline, please? Joseph, you guys, and Robert, you guys can hear us still?
Yes.
Yeah.
Hello?
Yes.
Yes, we
Can they
do.
hear us?
Yes.
Oh,
yes.
okay, good. Okay,
I'm
good.
not talking to.
Sorry, we were quiet and you were quiet. Okay.
You are
So
not
you see on
quiet.
fluoro, I'm gonna go
we are
REO.
quiet.
All right, I'm gonna go REO here in just a second. Let's take a look here. Okay, it's probably too much REO there.
Okay.
All right, we advance almost to the tip. Then I'm gonna withdraw the sheet so you can see there the device. That was just the tip of the device. Let's zoom in by one, Peter, please.
Okay.
Okay, we're zoomed in? Okay,
Yes.
good. So what I'm going to do now is I'm going to withdraw the sheet to express the ball of the device. So hopefully you can see that. And what we want to do, you can see, if you look on ice now, hopefully you can see both.
Underneath.
It's right there.
It's
The
great.
ball of this is right at the mouth. So I
Can we
advance
see ice?
everything. So I'm inside the appendage. Okay. Okay. I'm going to push this forward. I'm just going to deploy this one, Peter, because I don't know what's in there, and I'd rather just deploy it
Contrast.
and feel confident that we're okay. All right, good.
Okay.
You know, it's a little. Actually, it's okay.
No, it's
I
good.
wouldn't mind bringing it back a
No,
little
no,
bit.
no,
What do you think?
no.
No?
No.
Why not? Let me do a tug test. Maybe it'll come back.
Yeah.
Let's just pull it back a little bit. I mean, it's fine, but
It's fine.
just
Rick.
a little bit.
No, why?
Just a little.
No, there's no reason.
It'll be very
There's
little.
no reason.
There, that was it. Just a little. In fact, it's the same position.
I think it's.
I'm going to do just
Okay,
a little
fine.
bit. It's not. I'm not going to come back too much. So,
No.
all right, that's good. I like this better. Okay.
I cannot see anything.
I know. Hold on one second. Okay, there. This is good. I like this position a little bit better. It's
It's the
just
same.
No, it's a little further back. Maybe not.
I have a headache.
Okay, so we'll do a tug test here. So this is the way we like to do the tug test is to. Are we on setting 15 frames per second?
15.
What we'll do is we'll inject contrast, pull the sheath back, and then tug on it.
Right.
Are we good?
Yes.
Yeah. Okay. Nobody. No, not good. Okay.
Okay, here.
Okay,
15,
here we go.
15.
15.
Can we see fluoro?
Yes.
Yes.
Fluoro.
Perfect.
Okay. I think I'm happy with that.
Great.
Yeah, I was just looking to see if there's any clot in there. You know, when there's a clot, oftentimes you can see that staining, right? This one looks pretty good. I don't see any staining at all. Okay, I'm okay with this. Though I wouldn't mind bringing it back a little bit
Should be a
further.
little bit proximal.
You want me to bring it back further? I'm happy to. You know, it's an interesting question. When you have a situation like this, does it make sense to bring it back further? My bias is always to bring it back further. Most people just like to leave it like this, but whatever. It's fine.
Actually, can I mention something?
Let me let go of this. I'm going to let go of this
This
right
is
now.
very, very good advantage of flex because you can recapture several times. Actually, the original Watchman, the first generation Watchman or whatever, so it was really very like there were two limitations. Actually, one was that you should go with the sheet just inside the appendage. Sometimes it was very tricky to get not perforate the appendage. Second,
Let's put some color here, please.
you couldn't recapture fully. So actually, when you deployed,
color.
color
Yeah,
on
sorry, go
the
ahead.
ice. So when you deployed, you couldn't recapture without any fear that the anchors are damaged, right? So this Watchman flex
Sure,
is
20.
much more flexible to
20.
deploy.
20. Yeah. We always like to bring the Nyquist down to 20. Oh, no. That's not it.
20. Here, like quiz. Okay, good, 20.
Yeah, but the gain is too high right now. Yeah, that's better.
Okay,
So
okay,
we-
good. Nyquist here, down. Scale, down. Go down. Okay, 20.
Okay, good.
Okay, perfect.
And then let's gain it down. Now I can't see it. It looks like
Gain
a
off,
snowstorm
gain
in there.
Tiny gain. Perfect. More.
Okay.
Perfect.
Yeah, I like that. That looks good.
So no any leakage around
Yeah.
visible?
So that's
no,
good.
Not too much.
And then we'll also check the pericardium too. So we can get rid of color. No color, presume. Where is it? Okay, there we go. Okay, and then we always go in the right ventricle and make sure there's nothing. Pericardium looks good. Can zoom out a little bit, but it looks good to me. Okay, good. So let's go next door and deal with whatever's there. Okay.
So any questions about this? No, not really?
From the audience, no.
No?
Okay.
Okay.
Then maybe we should go next door
Okay.
before time really runs out. We only have about 90 seconds left.
90 seconds?
Yeah.
How much time we have, guys? I mean, Robert, Joseph.
So what do we have?
We are open, but maybe
Approximately
Vivek, don't be
15 minutes. 15 minutes.
15 minutes.
Okay. So let's take a look at what we got here. We're back in this room.
Oh.
Okay. Joseph, can you hear us?
Yes. Yes.
I can't hear them.
Yeah, we can hear you.
Okay, good. Okay, good. So in this room, so what you're going to see on the Cardo system on the left is the baseline voltage map that we did before we went live.
Can we see
So
Cardo?
can you see that?
No.
No.
Let's show them the Cardo map, Stepan. Okay, good. So you can see that. So that's the baseline voltage map. You see that it's, it's a relatively healthy, normal-looking atrium. Let's rotate that around so that they can see that, please. Okay, good. All right, now Toshi just did a post-ablation map. So let's see that. Let's see the post-ablation map, the current map. What's this? I don't know. We'll see. Let's see. Okay, so you can see, interestingly, it's sort of confluent. No, wait a second. Down here, though, there's no mitral line, is there? I think it's healthy down there. Let's verify that. I want to make sure that there's no problem. So I'm going to put in the pentarray again. As I said before, we don't see these things going all the way to the mitral, so I am expecting that it's going to be perfectly fine. But let's see, maybe I'll be proven wrong.
And is the voltage map
Aspirate, please.
before and
Aspirate. No,
after
aspirate.
during same rhythm, during this flutter?
I think the baseline, I don't remember if it was in the flutter or not. By the way, this is not typical flutter. We put a CTI line. This is something else.
I know, but in
Since we're a
general,
live case.
if you have different rhythms, then the voltage might be also be different.
It's true, absolutely, but this is real, I think. So let's just do a voltage down here. I want to make sure that this is okay. Okay, let's take. Wait, can you rotate that around a little bit, please? Let's put this over here, please. Stefan, show me where I am. Okay, good. No. Show me a left lateral or LAO or something. Okay, good. Yeah, this is good voltage here. You can actually see the electrograms too. I don't know if you can see the electrograms, but they're very normal looking electrograms here. Okay, very healthy electrograms over here. Okay, so let's see this again. So anyway, so this is the voltage map. We certainly will, but I agree with you, Joseph, we certainly should look at this again once you're in sinus. But given how slow this flutter is, I doubt there's going to be much of a change in the electrograms. But we'll see. Time will tell. Now let's see the activation map. So as I said, we did a CTI line over here. So let's see what it looks like. Can we switch to activation mapping? We have the right atrial map too, right? Good. Okay, so, and then do we have the left atrial activation map too? I think it's 6, map 6, isn't it? Yeah, close 5, please. And then let's make it a activation map. It's 6, guys. I don't know why you're going to 5. Okay, good. What's that? Yeah. Okay, so let's make it an activation. Good. Now, we weren't really paying, you guys weren't really paying attention to activation when you made this, right? I mean, this looks like gobbledygook. Let's set the force, let's set the scar threshold to something reasonable. So let's set the scar and make it, yeah. This is like, I don't know what this is. We gotta make this better. AP view, please. That's better. It's better, but it's uninterpretable. What is this? You know what? I'm going to just redo this. I don't know what the hell this is. We have a little bit of time anyway, right? So let's just do a new map, please. Let's do a new map. Remap. Can they hear me? I don't think they can hear me.
Yeah, we hear you. We are astonished by what you are showing.
No, I meant the people in the back. They don't seem to be hearing me because they're not doing what I'm asking them to do.
Okay.
I don't know what they're doing, actually.
You don't know too.
Can I start? AP view, please. Okay. Let's see here. Is our window okay? Yeah, I think it is. All right, I'm going to go ahead and get started. I need you to open up the electrogram window. I want to see these electrograms. Make it wider, please. Yeah. And go to 200 sweep speed on that. You know, it's interesting. I don't know if you guys have the stereotaxis screen, but it's like integrates everything, which is really nice except you can't click on anything. Let's go to 200 sweep speed, please. Okay, I can't wait for 200 sweep speed. Okay. Can we check these? Don't touch because there's too much noise here. Is it really coming from the appendage? I would find that very hard to believe, but it could be. Let's make sure there's no V, please. Yeah, there's no V. And yeah, do something to that additional map. The registration here is bad. Okay. We got to re-register something. It's horrendous. I can't interpret this stuff.
And why do you need registration? It's possible
Well,
to
because I'm not
without-
making a map. I'm just. I mean, if I was going to do a full, like a fan map or something, I certainly could. But given that we have a CT, I'd like to have the registration, right? Maybe I should make a full fan map, given that the registration is not good.
Yes, that's the reason I'm asking.
Can you re-register, please? I'm going to take some stuff in the veins just to help us with the registration of this stuff. Are you showing two maps on that screen? I think you're showing two maps, Stepan. Get rid of the other one. You're right, it is one map. You're right. Wow. Okay. And this is all just low voltage scar. Okay, and then let me go to this. Let me go to the mitral isthmus region. I mean, I think this is all like far field irrelevant stuff, but c'est la vie. Can you make sure we don't have a V there, please? Yeah, it's no V. So it's just colliding there, yeah? Okay. Show me AP view, please. What is going on up here? Is it really something interesting? I just don't believe it. You know, it's so rare that I actually see something where the appendage is important, that if that really is the case, it'll be highly unusual for me. Is it really here? No, I don't believe it. I just don't believe it.
I think you have problem with reference.
Well, why is my...
I see some changes of with reference
Cycle
signal.
length is, the cycle length is definitely, yeah, the cycle length is definitely fluctuating. It's a problem.
And cycle length is
I've seen that from the
fluctuating, yes.
beginning of the case. Yeah, definitely fluctuating. Very annoying. Just play this for me. Stefan, play this for me. Stepan, let's play. Sorry, they're like checking their emails, I think. Come on, can you go faster, please? We're going at like one millisecond a minute here. Change the sweep speed. When you go propagation, let's go faster. AP view. It does look like there's something coming from up here. Doesn't it? I think this is just interpolation here. I don't think there's anything really. But okay, let's go back to mapping, please.
Maybe entrainment.
Absolutely, but you know the problem is the cycle length is fluctuating, and when we tried to do entrainment before, we were just not in. It was just not easy, but we can certainly try again. I have no problem with that. Show me a PA view, please. I want to make sure the posterior wall is not involved. I don't think it is, but you never know, right? Yeah, I don't see anything back here. Okay, let's see here. Where's 1314? It's over there. Okay. Let's very low amplitude stuff. Here it's much higher amplitude. Let's play this again, please. Voltage map. I mean, propagation map. I want to see this again. Show me an AP view, please, and make it play faster. I don't know why it's not playing faster. It's very frustrating. Oh, man. You guys, can you make it faster or no? All right. Fine, I don't care. Show me a PA view. AP. Well, it's interesting. There's just this region up here, and then it just seems to come out right there. So I think we're going to go ahead and just target that for ablation. We can try doing some entrainments also. I'm just not optimistic because I think the cycle length variation is going to be a problem. But let's try.
Yeah, but if you have very long PPI, then even with some minor variation, it will show you that it's not the site.
Yeah, no, that's a very good point. It's good to rule out something. It's just not good to rule in anything. I suppose I could be surprised, and it may be completely outside of this location. We shall see. Is it flushing? Yeah, okay. Again, with this very big sheath, you got to be very careful of. You got to be very careful that you don't inadvertently introduce any air. So I'm extremely careful with these big sheets that I don't accidentally entrain any air as I put it in the left atrium. Okay. So let's zero the force here, please. AP top down, please. Okay, AP and top down. Okay, so do we zero it? We zeroed it. All right, let's do a quick entrainment here, please. Show them the electrograms. There's no point in showing me. What's the cycle length of this thing? It looks like it's varying between like.
Can we have a big
280,
screen
290.
with signals and a small screen with?
Yeah, you guys
video?
show
Okay.
electrograms. Okay, good.
It is quite irregular.
Okay, let's go ahead and train here, please. Let's show them the cardo image on the bottom, if you could. You don't need to show me. There's nothing. Yeah, you can hide me. Just show the cardo.
Okay,
Okay, great.
thank you.
And on cardo, why don't we go to a single view so they can see this bigger? Must be like postage stamps for them. All right, we'll entrain. What's the cycle length? About what? Okay, you want to go 280 then? Yep, go for it. Show AP, please. Okay, that's good.
entrain,
Stop.
Stop.
So that looks pretty good. And let's look on the other side too, right? You see whether, I don't know if you guys can see the cardo image very well, but I'm going to move it to the other side because it looked like it was actually a reentrant going around. Let's entrain here, please. Yep, go ahead. Yes, please, go. Yeah, okay, stop. That you say how quickly it entrained it. You know it's going to be in, right? When something entrains that quickly, it's pretty much in. Okay, let's go to pure cardo again. Can we ablate, by the way, Stepan? Are we set? Okay, good. Let's go to cardo again. So we can look at the electrograms. I don't see anything here. It just looks like very low voltage stuff. He's coughing. Can we give him something before he moves? Propofol, please. Can you hone in on the activation so I can see what was the earliest? Again, AP, please. You can put top down since we're showing them just a single screen. And hone in on the activation just so it's easier to see. So let's. I'm just looking here to see if there's any interesting electrograms specifically, but. What is that? Yeah, a little bit more to the left. Yeah. But the electrograms here, I don't see anything really interesting. Well, whatever. It is what it is. I guess we just have to find. There's some slightly interesting electrograms, I suppose. Let's set it for 35 watts, please. Okay, go for it. Ablation. What's happening in the cycle length? It seems to be slowing down a little bit. Is it slowing down? Or is that my imagination? Let's push the power a little bit. I mean, impedance is barely falling. We always have to be careful. You know, when the catheter is pointed up like this, if you're not careful, this is where you get pops and bad news. So we do want to be a little bit careful here. What's the cycle length now? Yeah, so it slowed down just a little bit, but not much. Okay, stop there. I'm going to look in here. Yeah, I know they're pointing me to this location because this is where it seems to exit the scar. Let's go again. Ablation, please. Ablation? Yep.
Can we see signals on one screen, please?
Can we show them the electrograms, please, on one of the screens? The Pruka? Okay, I need to see cardo. I can't not see cardo. Okay, good. You don't need to show ice. That doesn't really matter. Stop there. You know, I'm going to go more into the scar because it's got to be coming out of here somewhere. Go on here, please. Ablation. You know, what's really peculiar about this case is that this flutter rhythm was there from the very beginning, right? So, because I'd like to invoke that maybe it was because we did some ablation and, you know, there's some scar-related stuff there, but that's not the case. This flutter was there from the very beginning. So it's a weird physiology. I don't understand it. This is the kind of a case where you just want to I may do it. I was about to say this is the kind of case where we may just take out the flower catheter and ablate right here. All right, stop there. Let me just see this. Do one more entrainment from right here, please. What's the cycle length of this step on? 310. Okay. So entrain here at 290, perhaps. Yeah, did it very quickly. I'm sure it'll be in. Stop. Oh.
Oh.
That terminated it.
Yes.
That's not helpful. Let's reinitiate, please. Oh, I'm sorry. Use the CS. Oh, come on. Oh, there. Stop. Now we got AFib. Maybe it'll settle down. Give it a minute.
That's a different one.
That's very regular. What's the cycle length of this one? 240. Well, we may have another flutter that we have to look at. Let me, I'm going to put the pen tray back in. Let's get ready to remap again. Yeah. No, but this is something else, Peter. Yeah, I was thinking about it, but this is something else. This is a different type of flutter.
Yes, it is different.
So we got to map this guy.
Yes.
Okay. Okay, let's get ready to remap, please, with the pen tray. And it's, what's the cycle length again? It's 240? 230. We're making it faster instead of slower. Okay. Let's go. Show me the screen with the electrograms, please, and let's start mapping. I need to see the electrograms. Okay, so why don't you show, instead of showing them ice, show them the cardo and the pruca. There's nothing there on ice. And frankly, there's nothing on fluoro either. Okay, so can you flip the two? The cardo should be bigger. Well, maybe it shouldn't be. It's fine, leave it whatever. That's fine, that's fine. Okay, show me a PA view, please. Are we set to map? Did you guys set the window properly? I think you did.
Yes.
Okay. Just make sure we don't have too much V in there. And let's link the maps again so we can project the color directly on there. Do I need the headset? Yes. Okay. I mean, I can hear Robert. Wait, just slow down again. Yeah, what's the cycle length of this thing? Is this same slow, stupid thing? 330 milliseconds again. Fine. Since I already have this catheter in here, let's map this. Remap again. Show me an AP view, and let's just look at this one more time carefully. And if this is the case, I may end up putting the Farapulse catheter in. You guys, AP view. Am I ready to map or no? No, I'm not ready to map. No. You got to change the window, right? Are you ready? It's okay? Fine, you can fix it. Can you link it? Are you guys linking it? Doesn't look linked to me. Open it up. Yeah, good. Do you have the scar threshold set again, just like before? Whatever you had before. Let's just use the same setting. So, what? Set it to whatever it was before, Stepan. Well, pick something. Not 0.16. That's crazy. Let's do 0.1. The scar threshold. Yeah, 0.1 is more reasonable. Even that's a little high, I gotta say. That's okay. I want to really just focus in on what's going on anteriorly here. I think it's the same thing. Yeah, I think it's up here somewhere. Okay. It looks like the same activation pattern, right? I mean, we need more points, but I think it's the same thing. Avoid the V there. Go back in the beat buffer, avoid the V. Yeah, good. Show me, I'll just take a few points around just to fill this out a little bit. Avoid the V. Did you have the scar thing turned off? Turn the scar map thing on. Whatever you set it to, it's not on. So let's just fix it, please. I don't know. What is it set to now? I guess it is set. I guess it is set. You're not projecting the scar on the map? Yeah, add the scar, yeah. Oh, good. Okay, that's a little high. I think it should be 0.1 or 0.05. Okay, show me an AP view, please. What are we seeing in terms of activation pattern again? Yeah. Yeah, re-register, please. Re-register, please. It's re-registered? Okay. How about now? Okay, you want to get the catheter ready? So what I'm thinking here in this case, given that we're struggling with trying to make a lesion here, is perhaps we'll do a pulse field at that location. Let's play this, Stefan. I want to see that the activation is the same, and I want to do a quick entrainment.
I think the problem with activation map here is that you have very low potentials there, and then you can't map part of the circuit. So I would probably do what you suggest, put this flower and then do lesion, big lesion in that area.
Yeah, I think that's what we're going to do. Look, as you see now, the activation is just spreading from there and coming down.
Exactly,
So
but
exactly
there are no
what we need to
signals.
do.
So,
No.
oh, here yes, but not in that area of here. You have no signals practically.
Yeah. Okay, so we're going to go ahead and switch the catheter over. Here, put this one. Put this one on, please. Unplug this one, too. I got it. So we're going to switch over here.
Cable. Tomáš, caky.
Okay, I don't think we have much time here. Let's finish this. Is the wire in here? Okay, good. I think we're all set here.
Good connection.
Okay, we're just getting the catheter set up. I'm sorry about the delay. Okay, flush forward, please. Okay, stop. Okay, so wire back. Yeah, wire back. Can I see fluoro? They're looking at the cardo setup. Can they show fluoro, please? I should say, the system wasn't designed for this, so it's a little, it really is supposed to be for PVI. But having said that, let's take a look at ICE. Can you shake? I want to see the electrograms on this too. Let's set that up. Good. Let's go to the page with the. There's a page. No, there's a page that's already set up.
Yes. Okay. Perfect.
No, there's a page that's set up already for this. I don't know what he's doing. Can I see the electrograms on Farapulse?
Yes, working on it. Yes. Now it's
Come in.
I see.
We need to have a cato.
Oh, I see. Oh, cool. Okay.
Right.
So yeah, good. Okay. Wow, you guys are actually doing this right. I'm impressed. Yeah, actually, it is impressive. I'll give you that. If you guys see, so actually, this is nice. You can see on Cardo, they've actually put the, so they linked just the 5 electrodes that you can see on Farapulse. Because remember, only 5 of them do you actually have access to in terms of electrograms. So, well, why'd those just disappear? Oh, you guys are preparing the system. Okay. Stefan, how come there's only 4, though? I need 5 electrograms, right? Okay, now hold on a second. I want to make sure that I like this. Can they put fluoro up there too so they can see fluoro, what we're doing here? Okay, so, whoa. We need to see fluoro, X-ray, and what else do they need to see? And cardo, yeah. Fluoro, X-ray, and cardo.
Yeah, we see this. Yeah.
I said fluoro and X-ray, you know what I mean. Electrograms is good.
I mean, electrograms and
Sure.
carto is enough. Flora, we know
I
that
think
it's
you're gonna
there.
have. Okay, so let's just have these two then.
Yeah, that's fine.
Okay, so rotate the map down a little bit for me. I want to make sure I know where I am. Yeah. Okay. Let's see if it's really here. I mean, I don't, the other thing, of course, is the right side, but I don't think it's on the right side because we looked there before. And so I don't think that's the answer. I think this really is correct. Okay.
Before you entrained it here.
So I think, what's that?
There was entrainment in this septal part.
Right, we did. I mean, I'm gonna do one lesion a little higher up and then one a little bit further down because I don't think the higher up one is. I'd rather try to stay away from too much normal tissue until we're ready. Yeah, exactly. Wait, what do you want me to do? What do you want me to do? Like here? What do you mean? What do you? Oh, move the ablation catheter. Let's give him a. Yeah, okay. So let's just put this over here. How's that? Smart touch is over there. We're just putting the cardio catheter on the patient's chest, just so that hopefully the system thinks we're using it. Doesn't think like we're using it. I don't know. I think we're gonna just go. Can you just like save a picture or something, Stefan? That may be as good as it gets. Okay. Well, you know what? I'm going to go a little higher. Hold on a second. I want to just try to go less before I go more. Okay, let's go there, please. Let's save on Prerecorded, so go. Well, that didn't change at all. So, no, I don't want to do another. Well, I guess we should. No, I don't want to do another one. Unless I know for sure that it has an effect. Now, this is the area that's a little lower. This is the area that could be interesting. They didn't get a propofol, right? Okay. Hold on one second. One moment. Okay, I think I like this position. Well, I want to see it on cardio, though. Stefan, are we not going to be able to see it on cardio? Oh, there we go. Okay, let's go on there, please. Yeah. Well, it's still there. So that's, this is interesting. I wonder what this is. Let's go ahead and do a second lesion, too. Go ahead.
Let's go?
Yeah. Okay, I think that's probably enough. Right? Oh, you know what? Or we could go a little bit lower, I suppose, right here. He must have some sort of a deep septal flutter. It's the only way I can explain this. Rotate this up. Can I see it on cardio again?
Yes.
There it goes. I think this will be the last one. I don't want to keep coming down. But this is like right at the edge of the scar. I'm okay with this one. Okay, let's go one more time here, please. Interesting. Huh. I think we have to just map that. I don't know. I think we just need to define this better. Let's do a second lesion and then we'll go to yes. Okay, interesting. All right, so I think we need to map the right atrium a little bit closer. We did map the right atrium once, by the way, just so you guys know. So it's not like we didn't map it. We have to remap it. Okay. Let me have the pen tray. I'm going to pull in the right atrium. And let's remap this guy. Very interesting. Okay. Where is the
You have change in activation sequence in coronary sinus, I believe.
It is, but I think it also came back a little bit. Here, I'll just push it back in a little bit. No, it is
But
a little bit different.
little bit, but
Yeah.
There was clearly earliest was 910, and this is not now.
Yeah, definitely not. Let me have the, let's see the right atrium, please. And then show me the Petr, please. Yeah, we're gonna, let's make a map of the right atrium here, a new map of the right atrium. We could do a FAM. Yeah, let's go ahead and do a FAM map. Well, I want to see the cycle length now. What is the cycle length, like 300? It's the same 300, right? Can we start? You got the wrong catheter. The ablation catheter is sitting on the patient's chest. That's not going to help us. Yeah, good. Thank you. You're welcome. Okay. So you can hide the LA, I think. That's not going to really help me. It'll just get in my way. Okay. Okay, let's, can you zoom in a little bit? It's really a bit small for me. Okay, good. Okay, now I'm going to take some electrograms, okay? Yeah, you can keep collecting. I just want to... Now, I know you can collect and do FAM at the same time. I actually like to do it sequentially. And the reason is because I want to really pay attention to the electrograms. Oh, look at that. What's 1314? Just mark 1314 as something potentially interesting. Or is it may just be the activation coming out of the SVC, which means pretty boring. Let's shave that a little bit. Just shave the stuff that's bulging out in the septum. Yeah. Yeah, just cut that a little bit. Okay, let's do lateral just to make sure that it's nothing back out there. There is low voltage. When we mapped the right atrium before, there was some low voltage laterally in the right atrium. So we should pay more attention there, just to make sure. Okay, show me where I am, please. Right lateral. Well, that's interesting. What is that beeping? Hopefully it's nothing important. This is a mess over here. You see this? The electric, I don't know if you guys can see the electrograms. It really is very confusing. It actually looks like it's fibrillating in the right atrium. Interesting. If it really is sort of a complex atypical, I've seen this a couple times where there's like an area where you have, it's almost like multiple atypical flutters that can occur, and then you end up with variable cycle lengths, etc. I don't know if that's what we have here, but this is like worthless.
I would do some more entrainment.
It's very... Well, it's hard to entrain when the cycle length is... I mean, like if you look over here, for example, let's see.
I see it's a bit varying, but you are also mapping...
Here it's a little more organized. There it's a little more organized. So let's see. Maybe it'll settle down. Like right here, this is... I don't know. I don't know. It's a little weird. It's not really consistent. I mean, I'm not moving right now. So let's see, let me move somewhere. I need to put my, I'm going to use my sheath a little bit more and really just try to touch this en face. Okay. Rotate the map for me a little bit. Okay, now let me go a little more anteriorly and see if, okay. I think maybe it's my contact just wasn't great. Let's see here. Let's go back to this area that seemed confusing. Maybe it was just poor contact on my part. No, here I actually have good contact. I don't know what's going on with our fluoro here.
It should be possible to entrain here. It's quite a rigor here.
Yeah, it is. I want to just understand a little bit better. I love entrainment. I'm just a little wary of entraining when this thing changes so much. So I just want to have a little more information before I... We're going to have to make sure the phrenic is not nearby. What is that red dot? Is that even real? Yeah, just delete it. I don't trust it. Yeah, just delete them. Just delete them. I don't care. Delete all of my, some of those I don't trust, so I think my contact was questionable. Okay. Where's 13, 14? I know, it does seem, is it acting like, let's see here. There's a scar there. I think that it goes back and forth. You got to shave over here a little bit because there's nothing there. It's interesting. It's such low voltage. This patient has not had previous cardiac surgery or anything, so I don't know what the mechanism of this low voltage here is. Okay, I think I'm going to switch over to the ablation catheter to do some entrainments. Zoom in here on the area of interest. Well, it's not, I don't know if it's interesting, but. Can you shave over there? You see that? No, anterior to where this is. You got to shave right there. You see? Yeah, because it's just not all of it, just right here. You see my catheter is anterior right now. Yeah, good. Okay, and then let me just look over again. Just to be fair and play this. Oh, look at that. What is all this? I mean, the crista is right around here too, right? But where's 3, 4? 1, 2, 3, 4 over here. And 5, 6 is over there. Okay. Just play this for a second. I want to see what this looks like. And make sure it plays fast, not like this, very slow. Please try. This just looks like a mess in here. Where's 13, 14? Okay. It actually just looks like it's coming from right around there. There's so much interpolation. Why are we so zoomed in? Let's zoom out a little bit. I want to see the whole thing. Can you please play it faster? You got to be kidding me. Rotate around for me. What's happening over here? By the way, I think I told you guys, we did do a CTI, just a standard CTI line, which was blocked. I can't see. Okay, let's go back to, forget this thing. Show me electrograms. I mean, show me activation map. And let's look at septally, please. My splines are not appearing very. Yeah, go ahead and collect some more, fam. Though I really need to see the splines. This is just for anatomy. Okay. You know what? I'm gonna, since we were able to, I'm gonna have to do some entrainments. I can't understand what this just looks like a mess to me. I feel like we have to redo the whole map because something changed. You know, it's gonna, I hate to say it, but I think it's gonna take us a little while because I'm not happy with this. And as far as I could get, I think I just got anatomy. I didn't really get much of a map here, which means I'm gonna end up doing another map. How much time do we have?
Well, we can stay until morning, but I think we should cut it at one hour.
Okay.
I think, yeah. There are still some people watching, but maybe.
We may have to, yeah, we may have to, okay, let's see that. That was CS. Let's entrain. Okay, let me find a good spot here. Well, I guess if you end up cutting off, what we'll do is we'll show you tomorrow.
Yeah,
Okay.
that would be great, maybe. So if you can update us tomorrow.
Yeah, it's in train here, please. Yeah, I think we'll do that. Okay, stop. Well, that was in, wasn't it? Show it to me. It looks like it's in. Okay, so just mark this area as in. I just want to mark whatever entrainments are in and out. Let's look laterally, please. Right lateral.
So there was good entrainment. I did not see the signals properly.
Oh yeah. Sorry. Yeah, that was it was an excellent entrainment actually. It was perfect on.
Oh, okay. Yeah, sometimes patients have some like scar in the atrium or in both atria, even without any surgery or without any other procedure.
Yeah.
So.
Yeah, these idiopathic atrial scars, I have to say, those are, stop there. Those are like the biggest nightmares, I think. That looks long.
Yeah, this
that
is
looks
long.
long, but the cycle length did change a little bit. Just call this bad over here. What's the PPI is what? It's probably about 80 out. Yeah, 380. Okay. The cycle length is still fluctuating quite a bit.
I think there is a, the plan was to finish half an hour ago, and I think we cannot keep here stuff for a long time. So if you can update us tomorrow, that would be great. And thank you very much
we'll do that.
Thank you very much to all staff in Homolce and to you for nice demonstrations. And we will reconvene tomorrow afternoon, and we will update during live cases or during our program about today's case. Okay.
So good luck in this case.
Okay.
good luck. Bye bye.
Thanks. We need it.